Behavioral Health Meeting. My name is Al Roulette, and I have the pleasure of serving as chair of the commission. Today is the first day of our two-day meeting. We will recess today at 4 o'clock p.m. and reconvene tomorrow right here at 9 a.m. for another meeting. I just want to remind everyone that it is a two-day meeting, and thank you so much for making accommodations on your calendar. Now we will take roll and establish quorum. Please note that under Bagley-Keene Open Meeting Act, any commissioners who are participating remotely must keep their cameras on at all times and will be asked during roll call to disclose if they have any other adults over the age of 18 in the room with them during the meeting and the nature of their relationship with these individuals. Sandra, if you would please take the roll.
Thank you, Commissioner Roulette. I will ask those commissioners joining us virtually to please unmute your lines to help expedite the process. Thank you. Commissioner Alvarez.
Here.
Thank you. Commissioner Baer.
Here.
Commissioner Burnick.
Right here, online.
Thank you. And is anybody over the age of
No.
18 with you? Thank
No.
you. Commissioner Bontrager. Okay, marking absent. Commissioner Brown. Here. Commissioner Bunch. Marking absent. Commissioner Callan.
Here.
Commissioner Carnevale. Marking absent. Commissioner Contreras. Marking absent. Commissioner Designee Swartz. Here. Commissioner Cross.
Here.
Commissioner Fairweather. Here. Commissioner Fernandez.
Here.
Commissioner Gordon.
Here.
Commissioner Designee Polmano.
Here.
Commissioner Hill. Marking absent. Commissioner Larson.
Here.
Commissioner Madrigal Weiss.
Here.
Commissioner Mitchell. Here. Commissioner Robinson. Marking absent. Commissioner Southard. Marking absent. Commissioner Thomas Beckett.
Here.
Commissioner Sy. Marking absent. Commissioner Chambers. Commissioner Wilkes.
Here.
Commissioner Chambers, again, marking absent. Commissioner Roulette.
Here.
We have quorum.
Thank you, Sandra. Next, I'd like to ask commission staff to please go over the public comment procedure. Mariani?
Thank you, Chair. If you'd like live meeting transcription or closed captioning, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. If there are any members of the public using translation technology, please notify the chair so that we can be mindful. You may request to make public comment by submitting a card, clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. Members of the public can also email us public comment to be shared at a future meeting at publiccomment@bhsoac.ca.gov.
Thank you, Mariani.
Oh, sorry, there is a little bit more.
Okay.
For members of the public in the room, if you have not already, please use one of the green public comment cards located at the front to indicate you would like to make comment on any of the agenda items. Cards can be given to staff at the front table. When it is your turn to comment, I will call you to the podium or unmute your line and announce your name or the last 3 digits of your telephone number. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. We appreciate your understanding with this process. Thank you.
Again, thank you, Mariani, and please note that Commissioner Bontrager has joined us. Sandra.
Thank you, noted.
Okay. Agenda item 2, announcements and updates. Today's meeting, as I said earlier, will take place over the course of 2 days. We will take a recess at 4 p.m. We will reconvene here in this room tomorrow, March 27th at 9 a.m. Tomorrow's meeting will adjourn at 1 p.m. In line with our transparency efforts, we will continue to provide brief updates on recent contract amendments during all committee and commission meeting announcements for informational purposes only. Please note that contract amendments are negotiated between the commission and the contractor and must be mutually agreed upon. Oh, I also again, Commissioner Robinson has also joined us. Good morning. This month, we have 6 amendments to report and update to 6 of those update to 6 of the Commission's advocacy contracts. The amendment to each of these contracts includes work with the Behavioral Health Services Act's priority populations. Amending our advocacy contracts aligns this Commission and our grantees with the BHSA. This month, we also have 6 new contracts under $100,000, which have been executed under designated authority. These contracts are to translate our recently released Behavioral Health Services Act Partner Toolkit. The contracts are with Zabihulu La Ahalim Zar for Darcy and Farsi, Boat People SOS Center for Community Advancement, Inc. for Vietnamese, Equity, Languages and Employment Services for Cantonese, Mandarin, and Tagalog, Gigi Perry for Spanish, American Language Services for Korean, Cambodian, and Khmer, and lastly, Wei Fa Taher for Arabic. As we mentioned, we are working with translators to make our recently published BHSA Community Partner Toolkit available in languages other than English, again, including Farsi, Vietnamese, Cantonese, Mandarin, Tagalog, Spanish, Korean, Khmer, and Arabic. We hope this helps even more Californians participate in their community behavioral health planning process. And I'd like to, again, compliment the staff on the amazing work that you're all doing in this area. These resources, when they are available, they will be published at the following website: bhsoac.ca.gov/community-partner-toolkit. Yes, I said all of that. I'll say it again. That's bhsoac.ca.gov/community-partner-toolkit. We will send an email when they are available. If you would like to sign up to get that and other emails from the Commission, please visit bhsoac.ca.gov/sign-up. Yes, I said that too. Now I'd like to ask our Executive Director, Brenda Graylich, to share announcements.
Thank you so much, Chair. And good morning, everybody. So a couple announcements, exciting announcements this morning. So first off, our Innovation Partnership Fund request for application has been posted to our website. It was posted last Friday. So really want to give a shout out to all of the commissioners here, both through our full commission meeting and through our program advisory and CFC committees, for all the hard work to make that happen, along with all of our CBH staff team support, as well as all of our state partner agencies, our peers, our community-based organizations, providers. We had so much input to help really shape our grant, and so just want to give a shout out to everybody because that was a huge milestone to get that posted. Applications will be due on May 8th. So if anybody is interested or wants to hear more about the IPF grant opportunity, including any questions and responses, please sign up to get emails from our website. I will say it just like the chair said, bhsoac.ca.gov /sign/up. So you did that so much better than I did.
You didn't do it exactly like the chair did it.
What he said.
What I said, okay, everybody?
So, but big accomplishment, everybody. Thank you so much. We've already had so much interest in it so far. We have our bidders conference this Friday, and we've already had to increase our Zoom licenses just to accommodate the interest. So, again, really big shout out to all of the commissioners, the staff team, our committees, and all of our community and state partners. The next announcement for today is our TAY RFP. Oh, I'm sorry, that was on for announcements? Yeah. Oh, okay. I'm sorry. Well, then I will hold off on that until consent. Thank you. Thank you, Chief Counsel. Back over to you, Chair.
Thank you, Brenda. And thank you, Sandra. Next, I'd like to welcome Melissa Martin-Millard and Melissa Velasquez to introduce new staff joining the Research Evaluations and Programs team and the Administrative Services team. Please note there are written bios for each of our new staff members in the packet. Melissa, please come and introduce the new staff. Are they here?
Melissa? We're waiting for her.
Well, while we are...
Oh, she's just getting the thing. Okay, here she comes.
Thank you so much, Chair Roulette. I have the privilege of introducing two new staff members on our research side of the Research Evaluation and Program team. We first have Alicia DeLuise. She comes to us from actually Oregon, and has a PhD in biological anthropology from the University of Oregon, go Ducks, and a master's in psychological science from the University of Colorado. Her research is focused on evolutionary and environmental causes of health, including mental health, aging, cancer, and other chronic diseases. She brings a wealth of experience in both quantitative and qualitative methodologies, and we're just super excited that we convinced her to move further south into our state. So welcome, Alicia. And then our second research scientist, is Corey O'Malley. So Corey is a sociologist who specializes in equity-focused mixed methods research and evaluation. As a postdoc researcher in psychiatry and behavioral sciences at the University of California, Los Angeles, she led a community-partnered formative evaluation of youth crisis triage programs in collaboration with the commission. So this was actually a commission project, and so we've worked with and have known Dr. O'Malley for a number of years and are thrilled to be able to have her on staff as a research scientist. So for my team, welcome Alicia and Corey.
Melissa Velasquez could not join us this morning, but I am happy to introduce Claudia King, who is our new Senior Personnel Specialist. Claudia brings more than 14 years of progressive human resources experience, including over 5 years in state service as a personnel specialist. Her background reflects a strong commitment to excellence, collaboration, and service. She is deeply dedicated to fostering effective partnerships and empowering staff through clear communication, guidance, and support. And just on a personal note, she is just a little ray of sunshine. So we are really excited to welcome Claudia King.
I am back to introduce two more staff that I neglected to. We have been hiring so many people on our team. It's been wonderful, but even I've had a hard time keeping up with our hires. Okay, two more staff. We have Selena Regalado, who is joining us as a research scientist. She is going to be primarily focused on our universal behavioral health screening of children and youth. Selena comes to us from UC Davis Center for Reducing Health Disparities, the UC Davis Center for Regional Change, and the California Tribal Epidemiology Center. She holds a Master's of Health Science in Public Mental Health and Biostatistics from Johns Hopkins Bloomberg School of Public Health, and again, is just a wonderful mixed methods researcher who we're super excited to have on our team. And then on our grants and program side, we welcome Faye Sei-Chow. She joined us a couple of months ago from the California EMS Authority, where she led the statewide emergency medical services for children program. She, prior to that, worked for Covered California, so Department of Public Health. So Faye has a long career in state service, and we are incredibly lucky to have her joining the team and supporting our grants work, including our quality assurance and process improvement work. So welcome, Selena and Faye as well. Thank you.
We look forward to your contributions to the commission and hearing more about all the great work that you are doing, and thank you again for saying yes to coming work for the commission. This concludes the announcements for this morning. We will now move to our caring moment to help us center ourselves on the purpose of our work and the people that we serve. Prior to doing so, I just want to acknowledge that Commissioners Wilk, Sy are here, and I also think, yes, Contreras, yes, are here. So I wanted to acknowledge, and Robinson, if I didn't say that. So to all of you who are here this morning, thank you so much. We appreciate this. Thank you for being here for the two-day commission meeting. Again, as I was saying, we are now going to center ourselves around our caring moment. This practice is meant to remind us of why we do what we do and to share stories of moments that may be impacting others in ways that we may not always see. Today, we will hear from Commissioner Pam Bear. And again, Pam, it's great to have you here with us in person this morning.
Thank you. I'd like to, I'm very excited to share this update on a landmark suicide prevention project that the Commission helped fund before my time on the Commission back in 2014. Suicide prevention has always been a core piece of the Commission's work. Suicide attempts have long been an issue of one of the great state's most iconic landmarks, the Golden Gate Bridge, with an average of almost 30 deaths by suicide recorded each year between 2012 and 2023. While Mental Health Services Act funds had always been dedicated to behavioral health services programs, education, stigma reduction, and training, in 2015, a project to create a life-saving net at the Golden Gate Bridge was struggling to get off the ground due to rising development cost. Recognizing the net's potential to save lives, the Commission took an innovative approach by contributing MHSA funds toward completion of the net, marking the first time the Commission's funds had been used for an infrastructure project and reaffirming the Commission's commitment to suicide prevention. I am proud to report that the Golden Gate Bridge Suicide Deterrent Net was completed on January 1st, 2024, after several years of work. Positioned on the east and west sides of the bridge, the marine-grade stainless steel net is installed 20 feet below the sidewalk and extends out 20 feet over the water on both sides. The net is intentionally designed to be painful as a deterrent to jumping. The net has been widely recognized as a success, drawing even national attention to the drastic decrease in deaths by suicide since it was installed at the Golden Gate Bridge. In 2024, there were 8 deaths at the bridge, a 73% decline from the previous year. In 2025, this number declined to 4. with 0 deaths between June and December. The need for intervention has also gone down. Prior to the net, the Golden Gate Bridge Highway and Transportation District staff successfully intervened in almost 200 suicide attempts per year. In 2025, the number fell to 93 interventions. The net is doing exactly what it is designed to do. While today we celebrate the life-saving achievements of the net, let's not forget that suicide remains a critical behavioral health challenge in California. The Commission will continue to leverage data, community input, and innovative solutions to reach our ultimate goal: 0 lives lost to suicide. I'll now ask the Commission staff to please bring up a video about this amazing work.
For decades, it has been a serious problem at the Golden Gate Bridge, people jumping off and taking their own life. Well, now a new safety net aims to prevent that from happening. KCRA3's Ryan Curry spoke with a survivor about this. We want to warn you, he talks about suicide attempts in the story. May be difficult to hear.
Do you think that if there had been a net, would you even have attempted it?
We wouldn't be having this conversation because I would have been pulled to safety. I would have been given the mental health care I needed. My family would have been alerted. And this story would have never existed.
A story Kevin Hines believes is meant to save lives.
In the year 2000, due to bipolar, I leapt off the Golden Gate Bridge to try to end my life. In the water, as I was drowning and couldn't get back to the surface, something began circling beneath me, bumping me up. Witnesses and standers by would later recount to the Coast Guard and the patrol officers that a sea lion was in fact keeping me afloat until the Coast Guard boat arrived behind me.
He believes he was saved in order to serve his bigger purpose, leading others to get help.
I don't want anyone else to learn the hard way like I did.
He was part of an effort to get a safety net installed at the Golden Gate Bridge. The installation process took years and received pushback from people who thought the tax dollars should be used elsewhere. 1 year later, we're seeing the impact. Before it was installed, on average, 30 people each year would attempt to jump off the bridge. In 2025, 4 did so. That's an 87% drop, and the Golden Gate Bridge went months without a suicide.
A 7-month period with almost no suicides for the first time in 90 years. That's a century, Ryan. That is monumentous.
One big message Kevin believes gets sent by having the net installed is not just we don't want people jumping off, it's we care about you. Your life matters.
When you take away the opportunity, this is what happens. Suicides drop in that area. They drop in the metropolitan county around that area. Because why? Because you show people that you care.
Kevin eventually wants the number to reach 0, but in order to do that, he says they need to keep finding ways to care for those people.
When you show them there is another option besides suicide, A, they don't take their lives, and B, they get the help they need.
Help that will lead to them living a fulfilled life. In San Francisco, Ryan Curry, KCRA 3 News.
Kevin says he's working on expanding efforts to secure bridges nationwide. He says any effort towards reducing access to suicide helps people find treatment. If your loved one need help, you can call or text the national hotline. That number is 988.
I've been a pastor for over 20 years. This is a very important.
Thank you, Commissioner Bear, and thank you again, Cody, for the video. I'd like to now make an opportunity for commissioners to make comments. And given the topic and the importance of it, what I'd like to do, and I'll probably do this most of the day, is we'll alternate sides, but today I'll start with Commissioner Wilkes. And if you'd like to make a comment, we can just start on this side and go around. That way I won't take time to call on you. You can just make a comment But if anyone on this side, starting with Commissioner Wilkes, would like to make a comment, please feel free to do so, commissioners, and then we'll just go all the way around the room. Please, Commissioner Wilkes or Sy or anyone. Okay.
I am so grateful to be able to hear this news, right, as an advocate for suicide prevention, specifically with K through 12, and as a person who also has struggled with mental health issues, mental illness. This is beautiful. I'm so grateful to see that this is working. I'm grateful to see that the numbers are declining. I am hopeful, and I am hopeful that it will be zero. Just to be able to hear this is like a weight being lifted off of my shoulders. So thank you for sharing the news. Thank you for bringing this to light. Thank you for bringing this to my attention.
Thank you, Commissioner.
I'll just say that it's in prevention, it's really hard to have data to show what you've prevented. And so to have a prevention investment where we can say, like, we have saved this many lives is really inspirational. And I hope we can have more successes like this in the future. So thank you.
Well said.
Great report, great reminder, and I just want to remind everybody that this project was accomplished as a private-public partnership that leveraged dollars from a variety of different sources, and it shows what the possible is. A project that's too big or too expensive for one entity alone, but a potential life-changing, life-saving initiative as a result of the fact that people were willing to come together and leverage their ideas and their funding.
Skip past me, but it's really wonderful. And as a San Franciscan, I look at that, and it's just gorgeous. But also just sort of bringing up the importance of addressing means. And so, you know, the means of jumping off the bridge now is curtailed, and to remind everyone that firearms are very often used means of suicide, especially among veterans who I serve. And, you know, if you know someone who has a firearm and is struggling, to talk to them, to offer to take their weapon for, you know, the time, get a gun lock, you can get them free from the VA, and just how impactful addressing the means is.
Yes, Commissioner.
Sorry. I just wanted to say that this is really interesting because I remember going to the Golden Gate Bridge and saying, like, isn't there supposed to be a net under here? Because I swear I looked over and I was like, jump. Don't jump. Isn't there supposed to be a net there to save you? Because to me, I think that was the deterrent. But I also think it was a safety net. I know they said it's painful down there, and it probably really is, but in the very end of it, somebody saved your life. So I just want to say that. I think that we're putting our money in good places. I'm not 100% sure what a public-private partnership is. Is that like, okay.
That's when private dollars and dollars from other places,
okay,
like the commission, come together and do something as noteworthy as this. And so that in partnership, and none of the entities could do it independently. And we did it together, and it worked.
Did you guys hear that? We did that together. That's amazing. Okay, I'll let it continue. Thank you.
Any other comments? All right. Thank you so much, Commissioner. And we really appreciate this. And like many of you who were not born in the nation state of California, as I fondly refer to California, the Golden Gate Bridge is iconic. I never thought as a child I'd ever see it. It was something you saw in the movies or on TV shows. And then I recall the first time going across the Golden Gate Bridge, we were actually protesting and for more inclusion, believe it or not. And there we were going across the Golden Gate Bridge. And I remember thinking, I'm walking across the Golden Gate Bridge. And now to see this iconic symbol of California and what a life means in California and in San Francisco, that's important. And as Commissioner Brown said, this commission, all of us, why maybe not directly, but certainly as a commission are a part of that. So thanks to all the commissioners who did this prior to some of us coming on board. And then thank you again, Commissioner, for bringing this to light. This is a tremendous success, and you cannot place a monetary value on a life. If it saves one life, that is a good thing. So thank you, Commission. And now at this time, Mariani, I'd like to transition to public comment.
We do have some public comments on this item. Our first public comment is from Teresa.
Hi, Teresa Comstock with California Association of Local Behavioral Health Boards and Commissions. I wanted to also recognize the San Francisco Behavioral Health Commission. Several years ago, when they were called the Mental Health Commission, they made their recommendation to their Board of Supervisors for this netting and had to stay on the topic. So just, it took many years since that time, but want to really recognize that they had put forward that effort and the importance that they exist and that they're there for the public in order to ask for this type of change that's so much needed. Thank you.
Thank you. Our next comment is from Steve.
Okay. Can you hear me okay?
We can.
All right. Thank you. My name is Steve McNally. I'm from Orange County. I serve on a local board and commission with welfare and institution code responsibilities that are available to every county in the state, but sadly don't get implemented as written. But my comments are my own. So what I want to talk about today is something I've talked about in the past, but I had a revelation the other day. One-way communication, I think I've communicated to you the topics that I think are important, but what I've been unable to do is get any agreement because we're not allowed with the Brown Act or Bagley-Keene to go back and forth. And I haven't made an effort to reach out to all of you individually. And so as I see it for my son with schizophrenia, the siloed system continues. He gets tons of services because he's earned them. He's disabled and he has a support system that's aware of the system. But I'm just trying to reach out to you to ask for a couple of things. One is model the change you're asking for all of us, as my friend Ronnie would like to say all the time. So if you want everyone to come out and address self-stigma, I was encouraged by the new members who came out and told their stories about why they're here, why this is an important topic to them. Personal family suicides, personal journeys, family journeys. So many people want everyone else to talk about it, but they can't address their own self-stigma. The second thing is about misdirected frustration or misdirect anger. There's a lot of frustration in the state about the system. And so we watch in August before Prop 1 passed the legislature, this body and other bodies asking lots of questions. And then we saw it all pass straight through and win only by 30,000 votes. And now we feel the repercussions of it as we go through the BHSA presentations. And it's very hard to watch powerful stakeholders, powerful influence, not discuss things publicly and be able to feel that they're safe enough to discuss things openly and publicly, but say something differently behind the scenes. The only person that hurts is it hurts my son and others like him in the state. And then the last thing is, that speaks to culture and power and people who are concerned about equity, the imbalance of power for the voiceless. And then the other thing I'd like to talk about is how do we connect? And it's being started making slow movement, but how do we connect? Uh-oh, timer's up. How do we connect? If I could just take another 20 seconds, how do I connect the influence of this body to the Behavioral Health Planning Council, to the 900 plus people in the local boards and commissions, which you can all attend and add your influence, and include the 59 electeds in the state that don't see anybody's documentation, those being the Board of Supervisors or the cities that participate, they're elected. So thank you for your help, and I hope you have great meetings. Thank you.
Thank you. Our next comment is from Roberto.
Hi, my name is Roberto Velasquez, and I'm president and CEO of Southern Caregiver Resource Center. We're one of the 11 caregiver resource centers in the state of California. And I'm here today to speak on behalf of the 7 million family caregivers in the state of California and the over 490,000 family caregivers in San Diego County to ask that the mental health needs of adult and older adult family caregivers be included under the Behavioral Health Services Act. We understand uh, that under the new BHSA eligibility requirements, forthcoming programs must serve priority populations as outlined by the BHSA policy language. However, the plans on a local level, specifically here in San Diego County, and on a state level through California Department of Public Health, primarily reflect youth populations, and support for programs for older adults is lean at best. And we know that family caregivers frequently experience significant impairment and distress due to the demands of sustained caregiving, including moderate to severe depression, adjustment disorders, and generalized disorders. These are all conditions recognized as mental health disorders under the Welfare Institution Code and identified under DHCS guidelines. Yet, adult and older adult family caregivers are not recognized as specialty mental health criteria by the County of San Diego Behavioral Health Services. We're not included in the integrated plan, nor by the CDPH population-based prevention program, which were both recently published. And we know that family caregivers experience this negative impact leading to isolation, depression, as well as a negative bear on occupational duties such as employment or even their ability to care for their loved one, which we rely on. And talking about, suicide and the prevention of suicide, we know that family caregivers, especially those for long-term care, 1 in 4 will contemplate suicide more than once in a year. And we know that based on our CRC statewide reports, 70% report moderate to severe depression symptoms because of caregiving. Counties across the state, including San Diego, have cut programs like our Caregiver Support Services program that delivers 2 powerful evidence-based and community-defined psychoeducational interventions. With these cuts, this population would be left isolated, at risk, and completely vulnerable without any support. And my request today is very simple. It's include the adult and older adult mental health under the behavioral health services as a priority, either by the counties or by the state Department of Public Health, restore funding to our program here in San Diego, and direct DHCS and CDPH and the counties across the state to keep the commitment to age and dementia-friendly communities by incorporating these evidence-based and community-defined programs designed to keep unpaid family caregivers, especially those caring for loved ones with Alzheimer's disease, as a priority, because that leads to severe mental illness. Thank you very much for your time.
Thank you. And just a reminder for folks that this is a public comment for the announcements items. We will move to general public comment in just a few minutes. I believe that was our last comment. Thank you.
Thank you very much to everyone who made comment. And again, thank you, Commissioner Bear, for that amazing, touching, and heartfelt, caring moment. It's now time to move on to agenda item 3, the Executive Director's update. Transition to you, Brenda.
Great, thank you, Chair. Lots has been going on since we had our last meeting in January. In the packets, there you guys should all be able to see the ED report where I list out highlights of the different activities that we've been involved with since our last meeting in January. I think when I did the ED report in January, it was everything from the time when I had when I came onto the commission until January, and now I'm going to do it for every 2 months. So you'll see it's just been a continuing busy time here at the commission. I said it before and I'll say it again, IPF grant was released last Friday, so very excited about that. We also yesterday, SB 2003 passed the Assembly Ed Committee on consent. And so that is our bill for free online suicide prevention training to students over age 13, their families, and teachers. So very excited to have that continuing to move forward. We kicked off our strategic plan refresh at our January meeting with the commission, and we went ahead and had our first strategic plan advisory committee meeting in February, and I'll be giving an update on that this afternoon, as well as getting additional feedback from commissioners and our stakeholders today as we continue to work through that process. We put the request for the $4 million for all Cove Youth Drop-In Centers to continue, so we could do extensions on those contracts, so that we can continue capturing data for the evaluation, and that is reflected in the governor's proposed fiscal year 26-27 budget. And we've had 5 CBH committee meetings in February, so continuing to be quite busy as a commission team. In terms of projects, we had our community, as the chair mentioned earlier, our BHSA community partner stakeholder engagement toolkit that was published last month. We've got translations available, or that we're working on right now to get that translated into various different languages. And so we're hearing some great feedback on that so far. So big shout out and thank you to everyone who worked so hard and is continuing to work on that. And again, that's not a one and done, but that's getting it started and continuing to refine over the years as we move forward. We've been working on our continued CBH staff team operational excellence work that we're doing to strengthen our internal infrastructure. So we've got our CBH Wellness in the Workplace work group that's been meeting with our team members, working to develop an action plan for items that we can implement or efforts that we can implement, or recommendations that we can implement to improve our workplace culture here at the commission. We did annual performance evaluations at the beginning of this year, so those are all done. That's a Cal HR requirement, and so those have been done. We're continuing to hold our CBH all team meetings, and at our last meeting, our legal team provided training for all team members on our new conflict of interest waiver of funds forms, and so this is something to help support our commissioners and support our team members in identifying potential conflicts of interest early so that we can work through that. We're working on getting a training together for commissioners at our May meeting on both Bagley-Keene and conflict of interest, so more to come on that. We're continuing to fill our vacancies. As you heard, we had a lot of new team members join our team and continuing to do so. Our executive team and our management team is continuing to work with Leading Resources Incorporated to continue building out leadership skills. We initiated an internal quality assurance and process improvement team to help us just with our internal operations. We updated telework agreements, did our internal expectations documents, and then are working to improve data security as well. So lots happening internally with our internal operations. As far as what I'm working on, I'm continuing all of our, beyond that, all of our collaborations with our different state partners and our provider partner associations, county associations, really trying to keep the networking going. I've added veterans to that list now, so thank you, Commissioner Fairweather, for flagging that at our last meeting. So I did have a chance to start meeting with the veterans folks, which is great, and so I know I'm on their listserv now. And then continuing to work on the different various state task forces and work groups and lots of different committees just to try to make sure that, I'm able to provide information that I'm learning from all of you into some of the state efforts that are happening, as well as taking the information I gather from those state convenings to help inform our work. So, and then I've also been continuing to present at conferences and different convenings. Prevention has been a hot topic. We're hearing about it from our comments today, and just continuing to work through that. We had our prevention panel back in January, and so we're continuing to engage in those conversations through our CFC and on into additional work groups or listening sessions so that we can help influence and shape those policies. And then just wanted to flag for everybody that healthcare access and information on their workforce education and training work group. I know there's going to be lots of conversations happening. I think there was in the Commissioner Connector some information on different, like the State Behavioral Health Task Force, different convenings to weigh in on that. Workforce, I know, is at the forefront of so much work and the importance of what you guys I am very interested in terms of helping shape our behavioral health workforce at all levels. So that WET plan's getting developed right now. It's a 5-year workforce education and training plan. So just wanted to take a moment to flag that. So in terms of the upcoming priorities for the next 60 days, continuing to work on our strategic plan update. Budget conversations are well underway right now. And so we'll be having our hearing at the end of April. And then so we'll continue to work on or keep tracking that and let everybody know if there's any impacts coming up for us as a commission. And then just continuing to work on our internal operational excellence work and filling our vacancies. We have our executive recruitments underway as well. So, yeah, just keeping up that work. So happy to answer any questions from commissioners and then on to our stakeholders.
Thank you so much. Starting with this side, and Commissioner Alvarez, if there are any questions or comments, this is your opportunity, Commissioners. Thank you so much, Commissioner. How about this side? All right. Seeing no questions or comments, Mariani, is there any public comment?
We do not have any public comment.
Thank you so much, and thank you for your commitment to transparency and all the work that you're doing as our Executive Director. We appreciate it very much. Now I'll move on to agenda item number 4. That's general public comment. It is now time reserved for comments on items that are not on the agenda. All written public comments received before the meeting have been included in meeting materials. Please note that for general public comment, which is the portion we are in now, individuals may speak on topics not listed on the agenda. However, commissioners do not and cannot engage in dialogue as topics would not have been agendized 10 days prior to the meeting and thus would violate Bagley-Keene requirements. That said, CBH staff will follow up on topics as needed and appropriate. Amariani, please lead us in public comment.
Thank you. Our first comment is from Carly.
Good morning, commissioners. Carly Stelzer on behalf of the California Behavioral Health Association. Want to just keep my comments pretty snappy. We wanted to express our appreciation to the Commission for the attention and resources that you've all dedicated to the Behavioral Health Service Act implementation. As we're all very well aware, it's going to have very far-reaching changes and impacts that will significantly affect providers' ability to offer services and deliver services to the communities that they care for. We really appreciated the community planning process toolkit. It's been a great resource. We've shared it with all of our providers and they have all been very appreciative. So we want to just express our appreciation for that attention and want to urge you that as the implementation process continues to maintain that open dialogue with providers, especially we see the Commission as an opportunity for provider voices to be shared as behavioral health service implementation really takes shape. Again, we just wanted to express our appreciation for your leadership and commitment to ensuring that the Behavioral Health Service Act reform is implemented in a way that strengthens the system and supports people in being able to deliver and access high quality care. So thank you so much for your leadership.
Thank you. Our next comment is from Steve.
Did you say Steve? I'm sorry.
Yeah, no, so sorry. I went out of order. Go ahead, Stacy. You were next.
Okay, thank you. Good morning, Commissioners. Stacy Hiramoto with REMCO, Racial and Ethnic Mental Health Disparities Coalition, and Safe Passages. I'm so sorry I cannot be with you in person today, but I will be there tomorrow. But I really wanted to commend Brenda and the whole staff, Melissa and Kelly, for all the work that you did on the Innovation Partnership Fund. You really did work closely with the community. You had many listening sessions and you took our recommendations. We appreciate it. And I really want to commend you and thank you and good luck with the process. That's all.
Thank you. Next, we have Steve.
Hello, my name's Steve McNally. First, again, I'm still in Orange County. First, I apologize because I spoke at the wrong time, and but hopefully, those are the comments I would have made now. I do appreciate the opening where about the shared funding and that kind of thing. I guess I just want to make sure that you understand that my comments aren't because I don't think you all are committed or doing a great job and all that. My comments are maybe to address blind spots and to get the people with influence and the people know a lot of stuff connected with the people who are trying to use the system. And no matter what meeting I go to, and I go to a lot of them across the state, I go to the stakeholder meetings, I see the same faces. I see meetings that are structured so there can't be public comment amongst the stakeholders for that matter, much less the public. I would ask that maybe we consider tracking those, what's brought up here and what you can agree with, but you can't do anything about it. What you can agree with, but you would like to do something about it and reach out and expand your team of influence. Because there's lots of people who can assist you with things that maybe you don't think you have the time to do because you don't have the staff. There's a whole 3.2, there's millions of people in my county, 3.2 million. And at first count, they had 15 comments on BHSA. So let that sink in. I know I'm rambling a little bit and I apologize. I think the role is, are you to create product? Are you to facilitate the awareness of product that's already created in the state? We have so many people creating product that if we were to do a general awareness of directing change, which spent around 10 years on suicide prevention done by the schools, I wonder how many people are even aware of it, have seen it, or what the impact is. We have our AND study saying it's great, but I think we need to sort of look at what's the general awareness of the products that we're doing and where is that clock? Because I know I don't know how to do Snappy and I apologize. I do want to make sure I appreciate your executive director because I am a big fan and I know she's going to make a lot of positive impact and already has. But just, nothing makes difference than when people feel safe enough to speak openly and honestly without fear of retribution, even within the stakeholder groups that they work within and have been chosen to speak on behalf of the community. Oh, great. Thank you.
Thank you. That was our last public comment.
The executive director assures me that she did not pay you to say that, Steve, but thank you very much. Okay. All right, we will now move on to agenda item 5, the approval of the January 22nd and 23rd commission meeting minutes. At this time, I'd like to invite commissioners to offer comments or ask questions. We'll start again on the opposite side. Commissioner Wilkes, you all are doing so well with this. Thank you so much. Seeing no comments on that side. This side. All right, thank you. Mariani, please go ahead with public comment.
We do not have any public comment.
Thank you, Mariani. Now that public comment is closed, I'd like to entertain a motion that the commission approve the January 22nd, 2026 meeting minutes. Thank you.
Second.
All right, thank you. We have a motion and a second.
Thank you. We have a motion and a second for the approval of the January 22nd meeting minutes. I ask all commissioners joining us virtually to please unmute your lines now to expedite the vote. Commissioner Alvarez.
Abstain.
Commissioner Baer.
Yes.
Commissioner Burnick. Marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch. Marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale. Marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz.
Aye.
Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Pumano.
Aye.
Commissioner Hill. Marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal-Weiss.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Southard. Marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy.
Aye.
Commissioner Wilkes.
Aye.
Commissioner Vice Chair Chambers. Marking absent. Chair Roulette.
Aye.
Motion passes.
Thank you. I would like to now entertain a motion that the commission approve the January 23rd, 2026 meeting minutes.
Madrigal, we have a motion and a second for the approval of the January 23rd meeting minutes. Starting the roll call now. Commissioner Alvarez.
Abstain.
Commissioner Baer.
Aye.
Commissioner Burnick, marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch, marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale, marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz. Commissioner Designee Swartz.
Sorry.
That's okay. Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Pulmano. Commissioner Hill, marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal-Weiss. Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Southard, marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy.
Aye.
Commissioner Wilkes.
Aye.
Commissioner Chambers, marking absent. Chair Roulette.
Aye.
Motion passes.
Thank you,
Patty.
commissioners. We'll now move on to agenda item 6, consent calendar, and we're going to handle that in two ways. I'll speak to the first item, and our executive director will speak to the second item. This month's consent calendar includes one innovation proposal and one intent to award. The first item on the consent calendar is a county innovation plan. As a reminder, let me go back again. I'm sorry, I skipped something important. All matters listed on the consent calendar are routine and non-controversial and can be acted upon in one motion. The first item on the consent calendar is a county innovation plan. As a reminder, changes forthcoming with the BHSA include the removal of the innovation component. Any final innovation proposals that counties wish to bring forward must be approved by the commission and operational no later than June 30, 2026. Beginning July 1, 2026, counties will no longer be able to allocate funds to innovation components, and any unencumbered innovation funds will be used towards BHSA components, which include full service partnerships, housing interventions, behavioral health services, and support categories. With that being said, this month's innovation proposal is an innovation extension on early psychosis learning healthcare network for Kern County of $4,900,000. This innovation proposal aligns with the BHSA and includes plans for sustainability. Commission staff have sent the documents related to these projects to all commissioners, and a copy of the staff analysis of the proposal has been provided in your packet. Brenda?
So that second item is on the consent calendar is an intent to award for our TAE RFP. So I'm excited to announce that on November 20th, the commission, or 2025, I should say, the commission released the request for proposal to award $670,000 per year for a total of $2,010,000 over 3 years to a statewide organization to develop and facilitate a program that builds the leadership, advocacy, training, and education and outreach and engagement capacity of transition-aged youth populations. The application period closed on January 16th, 2026. So we're announcing the Commission's intent to award a contract to Pro Youth and Families. Pro Youth and Families is a Sacramento-based statewide organization that's committed to investing in young people and strengthening communities. Their work centers on building youth wellness and elevating youth voices through programs designed to create real collective impact. Pro Youth and Families has had a long track record of effectively engaging, mentoring, and supporting transitional aged youth. They currently lead several successful programs that place TAE at the heart of advocacy and systems change. These include their Behavioral Health Youth Advisory Board, the Sacramento Youth Mental Health Project, the Mind 16 Initiative, among other efforts. From 2023 through 2024, Pro Youth and Families partnered with the Commission and 20 local grantees to build the mental health literacy and advocacy skills of roughly 400 transition-aged youth as part of the Youth Advocacy Initiative. So under the TAE Advocacy contract, Pro Youth and Families will recruit and support TAE advisors to co-create a Leadership Academy curriculum. And this curriculum is going to cover leadership skills, advocacy strategies, behavioral health policy and systems knowledge, and effective communication. It'll provide TAE with the knowledge and skills to be leaders in behavioral health well after the program has concluded. So we look forward to partnering with Pro Youth and Families on this effort. Thank you, Chair.
Thank you. Starting again with Commissioner Alvarez, I'll see if there are any questions from commissioners. That side of the room? Seeing none? All right. On this side of the room, any questions?
No questions, but I love Pro Youth. I am definitely a huge advocate for Pro Youth and Families. So, yeah, excited for them.
Thank you very much. Mariani, would you please go ahead to public comment?
We do not have any public comment.
Thank you. Now that public comment is closed, I would like to entertain a motion on this, again, as it is on the screen, that the Commission approve the consent calendar that includes the Innovation Plan extension on Early Psychosis Learning Healthcare Network for Kern County for $4,900,000 and the Transition Age Youth Advocacy Contract intent to award $670,000 for 3 years.
So moved.
Thank you. Thank you.
I have a motion from Commissioner Alvarez. Who's the second?
Second.
Across. Thank you so much. I have a motion and a second for the motion is written on the screen that the Commission approve the consent calendar, which includes the Innovation Plan for Early Psychosis Learning Healthcare and the TAE contract intent to award. Commissioner Alvarez. Aye. Commissioner Baer.
Aye.
Commissioner Burnick. Marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch. Marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale. Marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz. Aye. Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Pomano. Commissioner Hill, marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal-Weiss. Commissioner Mitchell. Commissioner Robinson. Commissioner Southard, marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy.
Aye.
Commissioner Wilkes.
Aye.
Vice Chair Chambers, marking absent. Chair Roulette.
Aye.
The motion passes.
Thank you. Next item on the agenda is our advocacy spotlight. At each of our meetings, we invite one of our contracted advocacy organizations to share with the Commission the work they are doing to provide advocacy around the state on behalf of and with our vulnerable and most often underserved communities. The Commission contracts with advocacy organizations that represent needs of specific populations, consumers, diverse racial and ethnic communities, families of consumers, immigrants and refugees, K-12 students, LGBTQIA plus communities, parents and caregivers, transition-age youth, and veterans. Each of these populations experience unique behavioral health challenges that are rooted in systemic, cultural, economic, and social barriers. Our partnerships with these organizations intend to uplift their communities through advocacy, empowerment, with local behavioral health planning and state-level policy making. So for our spotlight, I would like to welcome from United Parents, representing the Commission's advocacy contract for parents and caregivers. We look forward to having you share with us. We're excited about the work that you do. Thank you for being here. United Parents, please, we turn it over to you.
Good morning. Thank you, Commissioners. Is it hot in here? Is it just me? We're a little nervous, but thank you for having us.
You're off to a great start.
Thank you. We have been waiting for this moment for quite some time, so thank you for this. Thank you for the opportunity to be here today. I'm Melissa Hanna. I'm the Executive Director of United Parents. I'm
Steve Warner. I'm the statewide grant coordinator with United Parents.
I'm Jolene Fresky. I'm a parent and advocate.
We're honored to share how parents and caregivers across California are helping shape the future of behavioral health for children and families. Our presentation today will highlight our statewide collaboration, the real voices of families, and recommendations to ensure parents and caregivers remain central as the Behavioral Health Services Act evolves. It buzzes. Is it supposed to buzz? Is that okay? Okay. I didn't know if I did something wrong. So this is a picture of some of our staff from United Parents. Our mission is to provide resources to empower, strengthen, and support parents and other caregivers who have youth and or children with mental health, behavioral, and emotional disorders. That's actually that picture is from a team building activity, and it was fantastic. So you could see some funny faces in there. More than 50% of our board and staff are parents and caregivers with lived experience. Our programs and services are predominantly in Ventura County. We have our Family Access and Support Team program, which has been our longest running program, and it's a contract with our county. It's all peer services, and all of our staff are peer support specialists who have worked hard for their certification as a peer support specialist, and we bill Medi-Cal. So our peers are billing Medi-Cal now through that program. We have a respite program. And excuse me, going back, that program is we help parents who have just received a diagnosis of their child's diagnosis of a mental health need, and our parents walk the path with the parents who just came into the system. We have a respite program, so we provide a break for the parents that may need it. All of our respite providers are peers, and these are typically mentors that help take the kids on excursions, work with the kids, and give the parents a much needed break. We also provide educational advocacy, so we have educational advocates who are also parents with lived experience, attending IEP meetings, 504 plan meetings. They go with parents to IEP meetings and help advocate on behalf of the child. We have parent drop-in centers where we provide, it's a kind of a safety net for parents experiencing any type of need. And then we also provide support groups in person and online. And then what we're talking about today is our statewide contract with the BHS OAC. And it's collaboratively, we have a few partners throughout the state, our local level entities, which we'll talk about soon, And collectively or collaboratively, we're called Parents and Caregivers for Wellness. And through that program, we travel the state and we provide training and education for parents and caregivers who are raising children with mental health needs, and we'll talk more about that. And we also recently started virtual rural support groups, and Jolene will talk a little bit about that.
Thank you. Can you hear me okay? So I'm going to talk a little bit about what Parents and Caregivers for Wellness is. That's our PC4W as we shorten it. It's a collaborative project that's led by United Parents. It was launched in 2017 to strengthen the voice of parents and caregivers and improve services and supports for families. We can't do this work alone, so we have 6 LLE partners that align with with the current population, and they're focused on the underserved and rural communities. They are the African American Health Coalition, which services the southern region, California Alliance of Caregivers, which services the central region, California Mental Health Advocates for Children and Youth, Plumas Rural Services, which supports the Superior region, Side by Side Youth, which supports the Bay Area region, and The Whole Child, which supports the LA region. We define parents, next slide, sorry. There we go. We define parents and caregivers as the following: adoptive, biological, foster, resource, kinship, relative caregiver, family friend, court-appointed special advocate, guardian, and legal representative. We do host 5 regional events a year, 1 in each mental health region. We travel the state and focus on rural and frontier communities and the underserved populations. We do a full day of training and education based on needs expressed by parents and caregivers in that county. We survey the parents prior to our event and determine what needs the parents have in that specific community. So we take the topics of what the parents need and bring it to them in our regional events. One of the most important things that we do after the event is we have a post-event advocacy meeting with local decision makers. We invite local decision makers from all over the county to join us on a call, and we talk about our findings from the survey, and we have our LLE partner talk about the event themselves. You can see some pictures from some of our events. Sometimes they are very rural. As you can see, that was Alturas, I believe. And we do provide full meals, free childcare, incentives, gift giveaways, and again, we connect the parents to local resources and support. We invite local communities to come in, partnerships, and have resource tables and share that information with the parents throughout the day.
So just talking about the frontier and rural communities, some of the barriers we wanted to address since we've been working in the rural communities, and we learned a new term, frontier, which was something we didn't know. And we've been to some of these frontier communities, and if any of you have been, there's no flights, much to Steve's dismay, directly into these locations. So there's a lot of driving, but we really enjoy it, and we've learned quite a few things. So I'm sharing these with you now. Some of the barriers, of course, there's critical services are far away. So typically, and even Jolene can mention this, a lot of the families, they make it a full day. If they have to go drive to, an hour and a half to get services for their child, then they make it a grocery shopping day as well, Costco run, whatever it may be, and get it all done in that same day. So we have been connecting our local level entities, like for instance, we work with Plumas Rural Services. We've been connecting them with local families and decision makers. We've been creating support systems at events as an extension of support. And some of the other barriers that we've seen, there's a lack of privacy. So because they're smaller towns or communities, some of the families have really been fearful or nervous about opening up because the fear of neighbors and others knowing too much. So as we've heard from some, if they're in a support group sharing about the issues they may be experiencing at home, and then they go to the grocery store and see that same person, it can be quite uncomfortable. So families tend to take matters into their own hands. So for instance, we've done some bullying presentations, and we've found out that parents typically will take matters into their own hands and not always they're not always the best outcomes. And then we have decided that our next Advocacy Day at the Capitol, which is on April 14th, and we have the Executive Director, Brenda, will be speaking at our event, and it's going to be a focus on rural communities. And we also realized, because of the privacy need, we decided to start an online rural support group. Why we did that was because families can, as you see on Zoom, they can join and mute them. Not have their face on the camera, and they can share any issues they may have. They can use a different name, but it's really to connect families from throughout the state that live in rural communities to share their own experiences and best practices amongst each other within their own communities. Through our partnership, we have been working with Plumas Rural Services, and through our partnership with Plumas Rural Services and others, we've built bridges between local families and decision makers, and we're continuing to expand our online support groups. Okay. And we serve diverse communities and needs. Our network is intentionally diverse, and our local level entities reflect the racial, cultural, and geographic diversity of California families. We translate all documents and have interpretation provided depending on the needs of the families. And you saw one of the translators on the screen that's been contracted is Gigi Perry, and you could see her on the bottom picture. She's a simultaneous interpreter, which is fantastic. We also, our surveys, we survey the populations. We mentioned we have a statewide infographic. I don't think they have that, do they? We had an infographic we wanted to share with you, which shows our survey results. We draft surveys to match parents' needs, and we hired a behavioral health outcome data system, BHODS, to help us achieve this in populations. We've been working with the African American Health Coalition in the Southern region, centering their work on African American and Black parents and caregiver voices. We've also been working with California Alliance of Caregivers in the Central region. They focus on resource and foster parents statewide. We've been working with California Mental Health Advocates for Children and Youth, otherwise known as CAMACE, if you guys have heard of them. And they focus on children, youth, advocacy for families across diverse racial and cultural groups. Plumas Rural Services is a trusted in rural and frontier communities, and they also serve intellectual and developmental disabilities. We've been working with Side by Side in the Bay Area, and they specialize in LGBTQ+ youth and family supports. We've been working with The Whole Child in Los Angeles region. They serve predominantly Latino communities, and they serve the intellectual and developmental disabled communities. These partners reflect the cultural, racial, and geographic diversity of California families. This alignment ensures parents and caregivers can access services in a way that feels authentic, relevant, and safe. And through this network, we've reached over 10,000 parents and caregivers and partnered with more than 300+ child and family serving organizations throughout the state. We already service the newer populations we also serve the new populations into our work through resource tables.
Next slide. There we go. Our annual Advocacy at the Capitol is coming up, like Melissa mentioned, on April 14th, and we do have the honor of having Brenda come and speak with us to our parents and caregivers. What we do is we bring 100 parents and caregivers from all over the state. We fly them in. We have them spend the night in the hotel, and then have a full day of advocacy. We meet with local district representatives in the afternoon. We match them with their local constituents and talk about a bill that we're going to be supporting for the year. This year, we are supporting AB 1851, and we have the honor of Assemblymember Gibson, who's going to come and speak to us in person as well. We advocate for children's behavioral and mental health. We network with like-minded parents and caregivers, and we connect and share stories. I think that's one of the biggest impacts that we do, is our parents get to talk to one another and share the stories amongst themselves. In the past, you can see a list of the bills that we've advocated for. I won't go through them and bore you with all of them, but they are very important bills that we have supported in the past. And this will be our 6th annual Advocacy Day at the Capitol.
Steve went too fast.
I'm sorry.
I was hoping for a longer break. So our advocacy connects both ways, which what we learn locally. So at our parent and caregiver training events that we discussed, we learn what the local parents and caregivers need, whether it be in a larger community or in the rural frontier communities. And we bring that information to the state. And then what we learn statewide, we bring back to each county. During every regional event, we connect with parents and caregivers, we collect feedback and share that information with county leaders. We also share our statewide parent and caregiver voice infographics, which include data from nearly 10,000 families, so counties can see trends and better respond to real community needs. This feedback loop keeps families visible in both county and state level planning.
Some of the feedback that we've received, I'll read a couple of them for you from our parents and caregivers. Advocacy for children's mental health is an important pillar in shaping the outcomes of future generations. This Advocacy Day is so empowering and positive. We're all leaving with more confidence and purpose. Thank you all. PC4W always treats its participants with so much care and respect. It always leaves events feeling inspired and empowered. And that's just a big impact on me personally, being a parent with lived experience, being able to make a difference in the community with other parents and caregivers and doing the work under this advocacy contract has been very impactful for me as well. And from one parent with lived experience to another, I'd like to introduce Jolene Freshy, who's going to talk a little bit about her story.
Hi, I'm Jolene Fresky. I live in a rural area. It's called Calpine up in the Sierra County. And I am from the Bay Area, to get that. It's a new life and it's awesome, but we have hardly any services. I am raising my great nephew. He's 14 now. He's had 3 open heart surgeries, 2 strokes. He's got CP, intellectual disability, autism, and it's so hard. He's been out of school for a year, and I just got him back into school. With Plumas Rural Service, they have helped me and advocated for the school district. Mental health, they do not understand mental health. My son has gone through hospitalizations. They can't keep him because he's on oxygen at night, so there's nowhere that will accept him for a week or 2 to get him stable. We finally have him stable, which is awesome. I am running a rural support group in the rural area with not a lot of success, but I hope it's going to take off because we have one in Spanish and one in English. We need, in rural areas, the frontiers, we need some help because I do not want my son growing up and going to prison, living on the streets because of his mental illnesses too. I just appreciate you guys listening. I've never done this before. And we just need help out there and grants to help our children in every areas, but the rural areas are hurting. Thank you. And I'm grateful for United Parents. I also now work with the rural services. I'm a DV case manager. I also have mental health, severe anxiety, and I wish I would have known about all this years ago instead of starting my life at 58. Instead of, I wish I would have started 30 years ago advocating for our children. And I think you guys are doing an awesome job, and thank you. I don't know what else to say. Thank you.
Thank you, Jolene. So just some recommendations for the commission. So as we look ahead, we'd like to share a few recommendations for consideration. These are ideas that we believe could strengthen statewide efforts to support families. First, we'd love to see a commissioner from the parent caregiver population serving as a liaison to this stakeholder group, ensuring our experiences stay visible in decision-making. Second, sustain excuse me, and expand peer-driven supports and respite care. These are essential for caregiver wellness and placement stability. Third, we'd like to tailor approaches to reach rural and frontier families who often face additional barriers. Fourth, continue to strengthen community-based organizations as trusted partners. And finally, as the Behavioral Health Services Act evolves, we encourage thoughtful consideration of sustained and flexible funding approaches that keep family-centered supports strong within the broader system. Families and CBOs are the bridge between systems and the people they're meant to serve. We ask that you help keep these connections strong. Here's some more information that you can visit our Parents and Caregivers for Wellness website. You can email or call us. There's my information. That's my personal cell. I realized I didn't put my work cell, but anyway, you guys all have access to it. And then here's Steve's information. You can see it there along with his phone number. I don't think that's not your personal, is it? It is his personal. Okay, you guys can just call us if you need to or text. And then you can see us on social media as well. Thank you.
Thank you. I'd like to now move to Commissioner's comments and questions. And to start, again, on this side, looks like Commissioner Tsai is actually ready on that side. So, or Commissioner Wilkes, if you want to make some comments first, and then we'll just keep going around.
Yeah, thank you all for coming and sharing this important information. So I know there's urban, suburban, rural. Does that mean that there's now frontier? Okay. Thank you for sharing that. Can you define that? I've had a similar question. Can you define what frontier means?
We'll let Jolene do that. She lives in a frontier. We discovered it through the parents letting us know that there's frontier communities, and I know I have it. I just can't think of it right now, so I'll let Jolene answer.
I don't know the whole thing, but I live in a little town called Calpine. We have no grocery stores. I drive 40 minutes to work, which is a beautiful drive, but to go shopping and grocery shopping, it's a distance, and appointments. I do all my son's appointments in San Francisco, so, but I'm willing to live in peace than to live in the city. So.
I believe it might also be a population under 500. And most of the frontier or rural communities we've been providing resources and training have had 500 or less. And so typically if we have about 10 parents attending our events, that's really successful. So that's what we've seen as frontier. Thank you for the question.
And just on the frontier, it looks like, according to Google Gemini, frontier counties are defined by extreme sparsity, typically having a population density of less than 11 persons per square mile. So it's kind of very specific. But a comment and then a question. As the son of a mother with schizophrenia, multiple suicide attempts, end of life, pretty severe health issues, caregivers are kind of the heart and soul of why I do the work that I do. I mean, I consider myself as a caregiver, and so I just want to thank you for what you do kind of across California, frontier and otherwise. Question, I noticed on the slide regarding caregivers, do you have kids as caregivers as part of the group, or is it mainly, because I didn't see like kids, son, daughters listed under the caregiver definition?
That's a great question. Well, we don't list it, but at our events, the siblings, that's a good question. We need to list that. We do have siblings who attend that tend to be the sole caregivers. And actually, at United Parents, we've hired a couple of siblings that are the sole caregivers for their siblings. But that's a good question, and we should mention that. But we do have either siblings will come with their parents and caregivers, and they're almost this extension of the parent, and they have a lot to say, and they've come to our advocacy day, and they also attend the visits and really advocate for mental health supports for their siblings. I think aren't they called the glass, are they called the glass, there's a term for it. I forgot the term.
I'll Google it later.
Yeah.
I know what you're talking about, though. I think just to point out, I think that, I've typically thought about caregivers as very broadly, and there are, while I think normally there are kind of parental or adults as the caregivers, there are situations where the kids are actually the caregivers. So thank you very much again for your work.
Jolene, let me just tell you, Miss Jolene, thank you for coming. Thank you for having the courage to come and speak to us in regards to your great nephew. I just want to say I'm very proud of you, right, for doing this, but then also for taking care of your nephew, being an advocate, not just for him, but for the other babies that we have here in the state of California. So let me just say thank you, and I'm proud of you. This was big.
Go ahead, Commissioner.
I also want to commend you, Jolene. Thanks for your courage, and you did a great job in presenting. And thank you all for the presentation. Just in general terms, what are your measures of success? How do you, at the end of the year, what metrics do you look at to say we did a good job?
I think that, thank you for your question. The impact that we have on the parents and the feedback that we get from our post-event surveys really hit home. And we always try to improve. There's always room for improvement, but we really focus on what we hear from the parents directly.
And when we use post-event surveys, we also use surveys at the end of our advocacy day, and then we just recently started contracting with behavioral health outcome data systems to help us gather more outcome data. We tend to be a small nonprofit, so it was just not our strong point, the outcomes and the data accumulation. We just started using Bonterra. We had spreadsheets is what we used, and it was very scary because somebody messed up one link and everything was, so we are on the path to starting gathering more feedback and data. We're very much more quantitative and carry the stories and share the stories, and realized we have to match that with our quantitative data. So we're definitely working on that. And then with the new requirements through the commission for our quarterly reports and our annual report, we've also been working with BHOD's behavioral health outcome data systems to help us provide that information more clearly in our annual and our quarterly reports. Thank you.
Thank you for your presentation. Greatly appreciated. And Jolene, excellent job. 58-28, you're here now, and you did wonderfully. So thank you for being here. My question is, I saw that you included behavioral health. Are you providing a lot of supports to parents, caregivers around who might have children experiencing substance use? And I was really curious about that. I think we're seeing more and more children with this, and I don't know that there's a lot of supports out there. So really interested in this.
Thank you for that. And, that's kind of been one of the thorns in our side. We're very, very focused on peer mental health supports, and we that's what we know and that's what we do best. And we've always linked with providers that provide the best substance use support. So, because it's not in our wheelhouse right now as an agency, and I don't want to water down the substance use services that are needed by just checking a box and saying, okay, we do this. So we partner with substance use providers. So when we have our parent and caregiver regional events, we always reach out to substance use providers and make sure that they are at the table or they have a resource table at every one of our events. Most of our LLEs also focus on substance use services. And in Ventura County, United Parents, we partner with our local behavioral health substance use services, and we have quite a few partners and collaborations with substance use service providers. And so it's more of a referral based, and we're really working right now, I think not only in our county, but throughout the state, of that closed loop referral system. So it's not something that we personally do or that we do at our agency, because we don't, again, I don't want to just check that box. We want to make sure that we utilize the services that, or the agencies and supports that do it best.
Thank you for your presentation. Just quickly, what are the sources of your funding?
For this specific contract, it's through the Commission for Behavioral Health. And but for the other services that we particularly provide, United Parents does in Ventura County, it's predominantly county contracts. We have probation contracts. We have I don't know, I don't really like using the word child welfare, but we have our child welfare contracts as well. So they're very county focused contracts. And then this is our statewide funding. And we also had some Sierra Health Foundation funding, and trying to think. And then, yeah, that's what I could think of. Sorry. Oh, Medi-Cal. Sorry. Yes, Medi-Cal. And then we just recently started ECM services. So we are have been contracted with Full Circle Health Network to be our liaison to connect us with our local managed care plans. And so we just started the ECM services. I mean, we just have our first two referrals in. And so we are trying to really braid all of our funding. And it was a recommendation by Ventura County Behavioral Health, which they were very helpful in helping the CBOs learn how best to braid our funding and what to do with all the changes coming through BHSA. So thank you.
Thank you. Thank you so much for the service that you're providing. It's a badly needed area across the state that hasn't been well served or even touched upon. So congratulations and thank you. Thank you for your story and your report. I have a couple of questions. As I look at your the bills that you've advocated for, so many of them have to do with training of school personnel and other initiatives that would happen at the schools. How is that working out? Do you have even anecdotal data on how those requirements are working out and contributing to the work that you're doing?
Typically, well, Steve works with Kamasi, one of our partners, and once we advocate for the bill, we keep the parents involved, everyone who attends, and we also have a very large parent and caregiver network throughout the state, and we typically will keep them updated on all of the updates related to each of the bills through our newsletters. And Kamasi, our partner, they put together a policy newsletter.
Policy update newsletter.
Every month, discussing each of the policies. And and we give updates to the families. And then we also, as an agency, our board of directors it's a diverse board of directors. There are also parents and caregivers with lived experience. And we have a couple of teachers on our board, and so they've been really involved in helping us advocate for these bills. And did I answer your question? Sorry.
Yes, yes.
I can ramble, so just like go like this, and I'll stop.
Yeah, yeah.
We see a lot of our parents struggle with, like Jolene mentioned, with school services. And so we really try to focus our events on the bills that we support, like the one we're supporting this year, to make some changes at the district and levels and in the schools themselves.
What is the bill, this year's bill?
It's AB 1851, and it will, I brought a little fact sheet. If I can open it. I'll just read you the purpose of Assemblymember Gibson. Assembly Bill 1851 requires the California Department of Education to establish a consistent statewide Tier 1 social and emotional learning, SEL, behavioral health, and restorative justice framework for public schools. So today it exists for schools. This is to mandate that they actually have to do it, rather than making it optional. And they have accountability towards that. That's what the bill will.
Okay.
There's not all information available on it yet. He's only released some information, but as we obtain more information, we'll make that public on our website.
Okay. And a final question. As you go around the rural areas of the state, are there particular counties that stand out doing a good job or a better job of reaching the young people that you're invested in?
Yes, and I just quickly wanted to go back to your previous question, and we also work with California Alliance Child Family Services, and I'm sure you're all aware of Adrienne Shilton. She tends to be our consultant. Personally, I go to Adrienne for everything, and because we are part of CACFS, we work with them on the implementation once the bills are passed, and she gives us updates, and then we update through our newsletters. So going back to your next question, can you repeat that?
As you go around the various rural areas, are there particular counties that stand out in the way they've been able to approach the work that you're talking about, perhaps better than others, or with more fidelity, are there places that have figured out ways to help reach these young people despite all of the limitations of being in a rural area?
Specifically, I don't remember the counties exactly, but what we do is we take the information that we learn from each county. It's like a dual conversation, and we take that information and share the successes with other counties in hopes that they'll take on the roles that the other counties do.
I'm trying to think. We've had really great success with Kern County, very much involved. We also, when we go to these meetings, we discuss the CPP process and what their process is, and if they've made sure, we talk to the decision makers and we make sure that they, what their process is in bringing in the community in that planning process. And then we will use best practices that we've seen. So I could be a little biased, but in Ventura County, I just feel like they do such, not because they pay us right. I'm not, I always have to say that, but they are great. I feel for CBOs, they've been really helpful. We have a rural area in Ventura County called Fillmore, and they've been so helpful in making sure that if you heard of Fillmore, we have a drop-in center in Fillmore, and actually the county covers that. And so we've seen what happens when we meet with local decision makers, when we talk to them about the issues that arise from parents and caregivers. We also give them space to let us know what their challenges are. So we're hearing quite a bit from them also about their challenges. And then they ask for our support in helping them understand how they can reach more of the frontier or rural communities. And when we have these meetings with them, we always bring in our local level entity who has that inside knowledge. And we try to also bring a parent to those meetings as well. But I don't want to throw anyone under the bus really and say this county is not good. But, there's a couple counties we've had some issues with, but the rural communities, some of the decision makers we've met, they seem to be a little stressed more than you would find in the larger communities. Like it's just there's like they're typically kind of quiet initially when we tell them the needs, and then when the floodgates open, you'll just hear they'll just talk about all of the issues that they're seeing. So it's been great though.
Well, once again, thank you for your presentation, and thank you for taking on a very difficult but such an important task. Thank you.
Again, great presentation. Question, and thank you for the question on the funding. So I just found out that you guys' contract through us, that funding ends in 27. And so this is such great work, and you do have braided funding. And so what happens when your funding runs out? Will these counties be able to still get these services? Because rural communities do struggle. And what I have found from experience in working in rural communities as a direct care provider, there's not a lot of Medi-Cal, so it's a bunch of hodgepodge or different CBOs that provide the services. And that's a real big concern, because when the contracts run their length, then those families have to find other referrals or services to continue. So because your work is statewide and it's so big and it does bring together so much great really impact. So what is like your plan for when this contract ends in 2027? And then do you guys see Medi-Cal as an issue for some of these communities? Because a lot of them don't really want Medi-Cal, but Medi-Cal is that funding stream that keeps us in there doing the work. So if you could just speak to that, because that is it's a big concern.
Thank you for that. And, our sustainability plan, part of it is that we hope to get funded again. Just throwing that out there. But also, we just started the ECM services, and it would be great if we could implement throughout the state. We've been working with Pumas Rural Services, and there's another thing too, in the rural communities, they're very busy, because it tends to be like one agency doing everything. And so even having them partner with us is a big ask. Like they were like, we just want to, when we met with them, they were like, we just want to make sure that our staff aren't going to be overworked. They're very, very concerned about overworking the staff and burning them out. And so we've been able to kind of almost be an extension and help them understand or be there at the table for them. Because we have a little bit more of a capacity. And then we've also brought in Pumas Rural Services and other rural partners to different committee meetings, and really making sure that they're involved in what's going on throughout the state, so that if we are not available, they have those direct connections. And then I'm trying to think of what else, but the Medi-Cal billing for the peer services is difficult, because prior to Medi-Cal billing, it was so much easier to say, go do what's needed. And now everything has to fit into Medi-Cal language. It has to be billable services. Somehow it all has to be linked to how we can bill for it. Whereas before it was like, yeah, go out to the community, and if you have to go take a box of food to this family, if you have to go drive them to the bus stop, and now, before it was if a parent wanted to just vent about like maybe their relationship, which affects the child, right? But they just wanted to vent about their relationship and needed that time, that someone to vent to. It's sometimes you have to like kind of reroute them and say, well, how is this directly related to the child? And it's tough, right? Because it wasn't like that before. It was like, yeah, okay, let's talk. and let's have some time and let's meet and you can keep the conversation going. And now it's so much more structured, which is hard for CBOs because we are not the systems of care that have all of that red tape in place. And so I feel Medi-Cal has put so much more red tape in place, and not saying like, right, nobody's doing anything unethical or anything like that. It's just that that extra layer of support is just, it doesn't feel as meaningful is how I'm seeing. But eventually we'll work around it and get to where it needs to be. But right now it's a little stringent. Did I answer that for you?
It does answer the question, but I do see often that Medi-Cal is the answer in some of the smaller communities, at least the rural communities, because even though the requirements are so specific, they're really for the benefit of the care, justifying the care. But in some rural communities, I just think it is the answer because once the funding is gone from the CBOs, that's it. And then they have to scramble for these services that are so needed for someone like her nephew. So I don't know. I just think that some of the rural communities need to be a little bit more educated to that and don't look at it so much as Big Brother coming in to be in your business, because that's why they're, well, in my opinion, a lot of the folks in rural communities are there because they don't want Big Brother in their business. But sometimes Big Brother has to be in their business when the families need the services. So there's some more education I see there. I think there's a gap. Because,
absolutely. Yeah. Even when we would go into some of the rural communities and they were saying, we don't have enough providers, enough, social workers or enough licensed providers, we would say, well, what about parent partners? Do you guys have parent partners? And a lot of the rural communities had absolutely never even heard that term. And that's when we have been educating about, so it's slow. When there's not even the parent partner term or a peer wasn't even in the vocabulary. So we started really putting that in their ear of, the parent partners and the peers and the peer support. And so I think, we've definitely got that going. And so it's a slow process, but it'll be there. And I've been a support for some of our LLEs in the smaller areas because we went through the process of Medi-Cal certification and how time consuming. And when you're a small, even us, we're 35 employees. It took so many resources to get certified through Medi-Cal. We're just still, actually right now is getting emails. We're going through our audit and there was like 150 policies, we have to have in place. And then through the ECM, we had to go through the PAVE portal. That is like, I had to ask my board of directors for their social security numbers. So there's there's a lot. And so I've been a consultant for a lot of our LLEs or our smaller businesses that want to go through that process and let them know what it takes. And then I've been available to help walk them through that process. So that's where we are with that. But yeah, I totally agree. And I thank you for that.
To you more about this because, again, I just see ECM as a blessing to small communities like this because it's a one-stop shop. And again, if they have Medi-Cal, and depending upon who your HMO is, it's a gift. So just my comments.
Okay, commissioners.
I'll try to keep my notes brief, but as other commissioners have remarked, it brings up so much. So Jolene, first and foremost, thank you so much for sharing your story. Melissa, one of the points that you brought up was IEP, and I will tell you, as a parent whose young son recently qualified for IEP, navigating that system in Los Angeles County where there is an abundance of different types of resources is challenging enough. I cannot think of how challenging that must be in one of these frontier or rural communities. And so I think the fact that you're doing this work is absolutely essential for all Californians. The other point that you brought up that I was so happy to hear is that you're able to leverage Medi-Cal to support peer services. And I recognize that this has been a topic of contention across the states. And I also want to empathize with you on this point of what it means to start leaning into Medi-Cal when our organization started offering outpatient Medi-Cal services prior to DMC ODS, we had to go through that same process of getting all of our board members sort of, names of their firstborn children, and it's really challenging to have these types of conversations. And all I can say is that I promise you that over time, it improves, mostly because I think you just assimilate to what that looks like. And I wholeheartedly believe, as an organization that's grown tremendously as Medi-Cal has come online, that the folks that you serve absolutely benefit at the end of the day. There is an administrative burden that's associated with it, no doubt. Yes, like we went through the exact same growing pain of feeling like we had so much more flexibility under these other funding sources. The truth was those funding sources were extremely limited. And now the access that our clients, as we call them, not patients, have today is far superior and more robust than it was previously. And so I can only say keep pushing through, because that will get better. And lastly, I took a note because there were so many things that I heard. I'll stop there in terms of everyone else chiming in, but I'm really thank you so much. And Jolene, thank you for sharing your story.
Thank you for that.
Thanks. Thank you so much to the three of you for your leadership in this space. It's really amazing. I had a hopefully quick question. So much of what the commission, I think, should be focused on is supporting with BHSA implementation. And one of your recommendations is around strengthening community-based organizations. And maybe it's some of the things you've already mentioned, but I'm wondering if you were to tell the commission the top one or two things that you think would be most supportive of CBOs at this moment in time, what would those be?
I would say direct contracts. In some of our counties that we visited, some of the counties do not outsource their peer services to local CBOs. And I feel that's very unfortunate. I think as a CBO that's all peer run and peer led, we have something that the children's systems of care don't have. And it's that trust that is built with the community. All of our staff are from the community, not saying that the county representatives are not, but it's different. It's a different connection. It's a different relationship. And as a CBO, we've heard this from parents, the turnover rate of their therapists and social workers through children's systems of care, it's so frequent. Even for us, we work with social workers for the IEPs. And sometimes, somebody will get a list and tomorrow the list is different of who's providing support. And so with the CBOs, I think just speaking for us and for other CBOs, our focus is making sure that our staff, that are the peers, are well taken care of, and they're there. We really focus on incentivizing our staff, paying our staff well, doing what our staff need, because we want to make sure that the family knows they'll be there for them tomorrow. And so, I also want to put this out there for everyone who's listening. If you are a part of a CBO, take care of your staff, because they are that direct line and support for those families who need it most. And so that's a big part of why I push for CBOs, not because I represent a CBO, but I see the difference. And I see CBOs struggling without that support, but they have so much heart, so much lived experience, and so much that they can bring to the table. And when they're struggling, it takes away from what they can give. And so I encourage the local behavioral health systems to contract with their local CBOs. They can bring something that you may not ever imagine.
Hi, Jolene. I just wanted to tell you thank you for sharing. Personally, I believe that when we tell stories and we hear stories, that's what helps shape who we are, right? And I think after hearing your story today, I think that you are helping with mental health literacy in the caregiver community. And I just wanted to let you know that, by sitting here today, you are showing caregivers that it's okay to go out and share their stories. So I truly appreciate that. I also just wanted to say, from a youth perspective to a caregiver, you are greatly appreciated. I just wanted you to know that we do care for our caregivers. All right, thank you.
Hi, thank you so much. And my day job is with the CBI, so I really appreciate your words about community-based organizations and the struggles. One question I have is, with a parent, just because the child comes of legal age doesn't stop the caregiving, but also adds on a bunch of complications in terms of them being, considered an adult legally and all that comes with that. So, like, you've been talking about school, of course, that's, important and everything, but that transition and so, does that support continue? Because, I mean, I know parents who, their children are well into adulthood and those responsibilities and stresses still, they're there.
Well, as an organization, we work with the youth through TAY through 25 per our county contracts. And what happens once they turn 18 is we bring them in as a partner as well. So we don't just speak with or work with the parent. We also engage with the youth once they turn 18, and then we ask them how they would prefer work with us, if whether working as a team with the parent or working separately. So we engage with the youth, but maybe Steve and Jolene, you can discuss. Flick, I'm doing all the talking.
I know we have a program up in Plymouth County. It's called the Live program, and so when you're 18, my son, I can't wait till he's 18. It's all for under an umbrella of disabilities, and they teach them life skills, and it's amazing. And that's also through the Plymouth Rural Service. But we need more help. We need more funding and support for the parents.
My son just turned 18, and once he graduates high school, that's when our services will end. And so, thank goodness, he's a client of Alta Regional Center, and they'll be able to provide a lot of services for him as well. So that's another avenue that we refer parents out to, is to try to get into your Alta Regional Center if you qualify. They've made it a little bit easier, I've heard, over the last 3 or 4 years than it used to be. It used to be a lot more challenging to become an Alta Regional client, and so we just encourage them to go that route as well.
In the rural areas, it took me 2 years to get my son back on regional. It was very hard. And so it's, because we're so far apart from the regional, in my case, it hasn't worked as much as it should have. But I'm hoping it moving forward, we'll get somewhere.
Thank you. Other commissioners?
Thank you. First of all, thank you very much, all of you, for an outstanding presentation and a wonderful concept that you've made into a reality. I think that the idea that a locally based organization can serve people within their own community, but also share their knowledge and their findings and their ability to network with others from throughout the state is amazing. And I'm particularly impressed with your 5 regional meetings that you do each year, and also the day that you spend in Sacramento each year on an annual advocacy day. I think it brings caregivers like Jolene, caregiver heroes like Jolene, to the forefront, and gives them the opportunity to network with other people who are facing similar challenges. It provides training and assistance, but it also provides inspiration, I think, and support and encouragement that is probably needed more than can be said. I think it also is a great example that shows that you can't solve every mental health problem with telemedicine, and it puts the human touch into the equation. You can't, give somebody a hug or hold their hand or do something through the screen that you can do in these settings that you have. So I think that's tremendous. I think it's a very thoughtful model and an example of an organization and a programmatic approach that really is worth repeating in other areas that could learn a lot from your model. So I just want to give kudos to you, Melissa, to Steve, and to Jolene for the outstanding work that you do.
Thank you.
A lot's been said about Medi-Cal, and since I'm the Medi-Cal Managed Care Plan representative here on the commission, I want to start by saying I'm sorry.
Say anything bad? I didn't.
Yeah.
No, it's all good. It's all good.
No. It's actually not all good. It's an unfortunate reality of the federal Medicaid program. In my mind, it's not built with a human-centered design. It's to defray and it's to limit costs and fraud, waste, and abuse, and too often that overrules the humanness element. However, with that being said, I just wonder, do you, it seems like the work you do would be in total alignment with the Families First Prevention Act, the Title IV dollars to go for prevention. Have you sought that?
Probably not. Again, we're smaller, and so sometimes it takes a lot for us to, we just have to find the right people to point us to what we need to do. Because even myself, I tend to be out, just this last Friday, we gave 120 farm workers diapers and food boxes from our local food share. And so we're all kind of in the trenches, if you will, and so we don't have somebody that really, hey, you should apply for this, but that would be great if.
Yeah, the Alliance is they should have the pulse of that statewide. I would lean into that. But the other thing is, under Medi-Cal, one of the community supports is respite services, and so that's another opportunity. If ECM goes swimmingly and you want to dip your toes even further, some of the work you do is also reimbursable under community supports of CalAIM.
Since it was fairly new to us, we're starting with ECM, then we'll eventually go to community supports and then CHWs. We just wanted to start off small, being that we're small, and then kind of go from there. But thank you for that. Yes.
Please.
Thank you for sharing your stories. I have a quick question. I don't want to be repetitive, but can you clarify the private dollars you're getting and how that factors in? It's great what you've done on the public side.
Can you clarify what you mean by the private dollars?
Private, charitable.
Sorry.
Because your story is amazing. You have a story to tell, and just like the bridge, the Golden Gate Bridge, there's public-private partnerships. And telling your story out in the communities, there might be an angel foundation. So I'm just curious.
Oh, sorry. Yes. We're working on it. Typically it's all public, and we've reached out to a couple of philanthropy groups, and also I can't think of the word for unrestricted funds. I can't remember anyway, we've reached out to quite a few, and it's tough because, again, we're limited resources, and so we do have a development director, and we're going that route on the donor cultivation and trying to get more donors involved in supporting us. We've been very, very focused for 30 years on sole contracts, and our goal is to diversify more, and that's just our comfort level. But with BHSA and all the changes, we've had to start being more creative, and so we're on that route of diversifying more and going into the foundations. Sorry. Yes. Does that answer your question?
Thank you so much. I also want to extend my appreciation to you, Jolene, for sharing your story and for being with us, and for just the connection that you all demonstrated to the work and to the cause. It was very clear in each of your presentations how passionate you are about this work, so thank you. I have a couple of questions. One is, and I don't want to be too repetitive either, but just for the commission, like this example of the capacity that they're providing to bill Medi-Cal, to actually utilize the very services that Medi-Cal has newly created, to do it well, like that's a case study. That's something that we could help others in our network, because this comes up in every single topic, whether it's peers, whether it's community health workers, whether it's dyadic care, whether it's ECM. There's all these exciting changes in Medi-Cal and no one can bill. So the fact that you're doing it, Ventura County, shout out to them, great. How do we uplift that and make sure that there are others taking those opportunities, and the commission's responsibility or opportunity in that? So thanks for sharing that. Would love to learn more. Mark, I love what you said about the Families First Prevention Act. I just learned about that in San Diego County and what they're doing and trying to be creative. So I would write that one down for follow-up. My other question, though, is, I really resonated with you saying about how under-resourced certain areas of our state are. And the reality is more and more of our communities, whether it's our communities of color, immigrant communities, are moving to those rural areas because our cities are too expensive. And they're moving to areas that are not as resource-filled, that are not as potentially welcoming. And so I'm curious, what has that environment been like, as the external environment on immigration enforcement, as the external political environment has been quite harsh to certain communities, marginalized communities? Have you seen an uptick in the need for mental health supports, and how have you responded to that? And where can we be better partners to you all in that? That's one question. And then my other question that I didn't hear you talk a lot about is young children, 0 to 5, and the connection of the birth experience, the mother's prenatal care, and how infant and early childhood mental health show up in your work. Again, a lot of the legislation was related to K through 12, not child care settings. And I'm not saying you got to do everything, but I am curious how it comes up, particularly for parents and finding those support services. And then last thing I will say is, so much of what we're trying to do to improve care delivery is grounded in Medi-Cal. And Medi-Cal is significantly under attack. We are about to experience some of the greatest changes to Medi-Cal with the implementation of HR 1. And so as you all are building advocacy capacity in your parents, to think about how they can be advocates for Medi-Cal as a program and sustaining that program, we would love to be partners in making sure that happens, because those stories are what matters. It's what people are going to listen to as to why the Medi-Cal program needs to stay as strong as possible. And you all are leaders in making that possible for us. So thank you.
Thank you. And to answer your questions about, in Ventura County, particularly, a huge portion, I think 75% of our population are Hispanic, Latinos, and or Latinx, whichever is preferred. But and we did see, actually, there was a decrease in. It wasn't a decrease in need; it was a decrease in people showing up, right? And so we've had to pivot. And so, for instance, where we would meet families in locations, some of the families were very scared, even though they've built that rapport. That trust just went out, even for people they felt like they can trust. We do not promise safety, because that also, in and of itself, can deter a family, because we just don't know, right? And we try to be as safe and intentional as possible for our families. At our drop-in centers, we have a signage and we have information for the families. We've provided many presentations on how to get pro bono services, legal services, and we've also seen, now it just seems like the trust is building again, and we're seeing a lot more families coming in for just, it's not even mental health, right? It's all the underlying issues of food, and some of the families are overworking, because some families aren't working because of fear. So those who are there are working double and triple shifts. So we're seeing the issues with the siblings now being the caregivers for a lot of families, because the parents aren't there, because they have to make a living. So we're seeing a lot of different needs that we never saw before. I mean, they've been there, but I think they're just more pronounced now. And especially at the schools, some of the parents were afraid to send their children to school for fear of, ICE retaliation. And we've walked alongside them and said, you have to send your children to school. And, our advocates are all Spanish-speaking parents with lived experience, and have talked to them about, we're here to work through this with you. And Yeah, and we've actually grown more at our drop-in centers than just providing mental health services. We are also providing food, and we provide emergency assistance to some of our families for rental assistance because, our state is so very expensive. And of course, taking care of our staff is very important because they're the ones that are out there doing this and seeing this hard work, and seeing how difficult it is for the families. And I think for the 0 to 5 question, I don't want to check a box just because it's necessary. Like, you have to do all these things. We do what we do best, and we will expand on what we do best. But when it comes to the 0 to 5, we don't see a lot of referrals for 0 to 5. We are seeing more now, and it tends to be because our county, Ventura County, has opened up our access lines. There's not those secret terms that you had to use in order to get services for your kids. Families can call and say, I'm just experiencing some issues. And a lot of it tends to be co-parenting issues. A lot of divorce is causing some severe trauma with the 0 to 5 population. So we've been focused on doing co-parenting training and really making sure that both parents are involved in the services of their children. But it's kind of a good and bad thing, right? You don't want to see children that young going through the system, but it's good to see that the parents know the earlier that they get in, the better outcome for their children. And then we really have a great connection with First Five throughout the state. We've worked with First Five all over the state, and we also have a great connection with our LLE, which is the whole child, and their focus is on the 0 to 5 population predominantly. So we have a lot of partners too. So we're not just checking that box. We make sure that we get the direct service of those who do the best for that population.
Yes, one last comment.
Sorry, thanks again for everything you do. It's so inspiring. It comes to my heart. And I imagine your little car driving over the hill into a dark area with all the light, a car full of miracles. It's amazing. I was just asking two things. One, how do parents find out about you? And two, I'm wondering if what you do, it seems transformative to me, if there's any part of what you do that might qualify for our Innovative Partnership Fund. So that's
I'm
the next
registered to attend tomorrow. So I'll be at believe me, when it came out, I was like, oh, I can find a lot. But Jolene, did you want to discuss maybe?
Melissa and Steve through the Family Empowerment. It's in Plumas County. They've been helping me for about 3 or 4 years. I've been going to the Capitol with them. They actually helped me find my voice. And with the Rural Service, they care about the people that work for them. Mental health is a very big for us to take care of ourselves so we can take care of other people. So they helped me find my voice, and now I'm like an advocate for domestic violence and my son with mental illnesses. But also we need a lot of things for recovery too, for drug addiction, because that goes hand in hand with mental health. And in small communities where I live, well, not particularly where I live in Sierra County, but Plumas County and other areas, there's a big drug issues there, lots. And I know there's help out there, but you have to want the help to get the help. So I wish we had a drop-in center kind of like what you have, because I think more people would come and learn and be educated about mental health and drug addiction, because it's hand in hand. For me, it's hand in hand. So thank you.
We also have newsletters that we send out. Everyone who attends our events, we put them into a pot and we send them information, and then we make sure that they share that with other parents and caregivers throughout the state. Our local level entities, they share, and then we are on social media. Not the best, but it could use some work, and so those are ways that we try to reach out.
We are now going to transition to public comment, and for members of the public, we are going to limit that to 1 minute, as the hope is that many of the questions or comments that you might have been represented by the commissioners in the room. With that, Mariani, I'll transition to you.
Thank you. We have currently 4 public comments. Our first comment is from Lisa in the room. Oh, and then Lisa, if you could press the button until it turns green. There we go.
Perfect. Good afternoon or good morning. I'm Lisa Tadlock with the Office of Youth and Community Restoration. We are an office under California Health and Human Services. I loved your presentation, and I'd never heard of you before. Our work involves working with youth connected to the youth justice. But really quickly, I wanted to share, because this may answer some of the questions that the commissioners brought up too, is number one, I heard you say probation, so I'd love to connect with you later about that. Number two, we are funding right now through Sierra Health Foundation, a CBO, capacity building to train CBOs around the state to access ECM. And so we've dedicated about $16 million to this effort. So again, hearing that your experience, love to again connect, because we are always looking for people to share, their experiences. Number two, we have started a rural collaborative in the north, including frontier counties. And that collaborative is focusing on, right now, our rural counties are developing their county behavioral health plans, they're developing their CalAIM justice involved plans, and they also write an annual youth justice plan for us to get our funding. And so we knew that this was
Thank you, Lisa. Your time is up. If you could please wrap up your comment.
Okay, sorry. We'll talk later. So,
Thank you.
Yeah, thank you.
Thank you. Thank you.
Thank you. Our next comment is from Teresa.
Hi, Teresa Comstock with California Association of Local Behavioral Health Boards and Commissions. And I'm so impressed by the work that's being done, and just want to, our association would like to see this extended and increased. I wanted to call attention to a legislation related to caregivers and increasing the workforce, and especially youth that are caregivers. It's sponsored by the Association of Regional Center Agencies, and my own association is supporting it and has offered to also sponsor it. It's AB 2324, Youth Caregiver Career Pathway. The legislator is Gonzalez. So wanted to call your attention to that. Again, it's AB 2324, and I'm hoping that maybe the commission will consider this legislation also. Thanks.
Thank you. Our next public comment is from Laurel.
Good morning, and thank you so much. Your organization is so impressive. Your scope of work, both on the front line in Ventura County and statewide. So that's very inspirational. And your emphasis on the family, which is so important for really most of the people, or the majority of the people in the state, now that we're a majority minority state, and with refugees and immigrants. And is that what you meant by newcomers? I'd like to know. And last, you spoke a lot about building Medi-Cal. And I guess if you could just estimate in your head quickly, how much did it cost you in dollars to become Medi-Cal certified? And how long will it take for you to then pay that off with the Medi-Cal funds you receive? Thank you again.
And you can provide that answer to commission staff and email that to them, and they'll make sure that that information is disseminated to members of the public.
Thank you. Our next comment is from Evelyn.
Hi, I'm a parent advocate with Bayfront Youth and
Family Services, and I met Melissa at a bowling. Sorry, I'm a little nervous. I met Melissa at a parent partner symposium in LA County with United at United Parents, and I've been going for the last 6 years to Advocacy Day, and her and Steve have been helping me learn to use my voice and my lived experience to help others for the last 6 years. And this has impacted me to coach other parents to use their voice. And this has helped generations change together using their voices. Thank you.
Thank you. That was our last public comment.
Thank you so much, Melissa, Steve, and Jolene. Commissioners, I've chatted with Brenda, and given the robust comments and questions, we are going to expand in this section at future commission meetings to make sure that we can adequately accommodate the time necessary to really demonstrate not just that this really is the heart of the commission, but to our presenters. And again, thank you so much, presenters. You did a tremendous job. I appreciate your responsiveness to the questions and providing that information to the commission via email. Looking forward to hearing more about the great successes that you will continue to advance for families and caregivers in the state of California, especially in frontier communities. Thank you for teaching us. Thank you for inspiring us. And obviously, I want to say that it's reflective in what I'm about to do with the agenda, because commissioners, we're going to just keep working, okay? But we're going to keep working because we had a tremendous presentation. So on behalf of the commission, thank you very, very much. Thank you.
Thank you.
Thank you.
Okay, we are officially behind schedule. No surprise. We are going to skip the break, the official break. You can take an unofficial break, but we're paying attention to quorum. So again, we're going to skip the break. We're going to move to agenda item 9, the Commission's 2025-26 mid-year budget report. We are now going to hear a mid-year budget report on the Commission's budget. We hear this report each year in accordance with the rules of procedure. We will hear from Lauren Quintero, Acting Deputy Director of Administrative Services and Performance Management. Lauren, please come to the podium and present for us if you are as you're ready.
I'm ready. Good morning, everyone. As Chair Roulette said, I'm Lauren Quintero, Acting Deputy Director for Administration and Performance Management. Today, I will be briskly walking you through the Commission's mid-year budget update for fiscal year 2025-26.
Bless you, Lauren.
In the interest of time, I'm going to condense this presentation, but I encourage everyone to check out the materials in the packet, as well as the recording of the February BFA meeting, where I wax poetic about all the numbers. So this first slide shows the California budget process. As you can see, the fiscal year starts July 1st of one year and runs through June 30th of the next year. So this presentation represents expenditures from about halfway through our fiscal year, which means it's time for the budget update. Each year, the governor's budget allocates funding to the commission in two broad categories: state operations and local assistance. I'm starting with state operations, which includes personnel, operating expenses, and the commission's budget-directed items. Our personnel budget had a net increase of $228,000 since July 1 of last year. This reflects several salary and benefit allocation changes. It is very common to see mid-year adjustments in the personnel category that reflect changes negotiated by bargaining units as well as other state-mandated adjustments. Move on. As I dive into our financial position at the mid-year 2025-26, I want to start by explaining the columns you'll see on this and the following tables in the presentation. The first column, mid-year budget 2025-26, reflects the budgeted amount for each subcategory in the state operations portion of the budget, as adjusted at mid-year based on the changes I explained on the previous slide. The next column, year-to-date expenses, shows the money that has already been spent. The check has been mailed out. Remaining encumbrance shows the money that is tied to a signed and valid contract between the commission and another entity. For example, if we have a contract for $5 million, we've spent $1 million, the remaining encumbrance would be $4 million, and that would appear in the remaining encumbrance column. The next column, designated, reflects two things. First, contracts that the commission has approved for procurement or award, but have not yet been executed, so the funds are not yet officially encumbered. And second, expenses that are not tied to a commission contract but are still expected, such as our rent costs or staff salaries. Estimated total combines year-to-date expenses, remaining encumbrance, and designated funds to project the likely total when the fiscal year closes. Finally, variance shows the difference between the mid-year budget amount and the estimated total. Now that I've covered the definitions, let's look at the numbers. Personnel, salaries, and benefits has no remaining encumbrance, and staff salaries and benefits is an expense we cannot encumber. With our current designated funds, we are projecting a positive variance of $1,019,773 in the personnel category. This variance is available for us to spend in the areas where we are projecting a negative variance. Our mid-year operations budget has a variance of negative $563,811, which we are using the salary savings to cover this variance. The mid-year budget direct items category has a positive variance of $5,000. So altogether for fiscal year 2025-26, the mid-year budget is $13,162,000, leaving an overall positive variance of $460,962. Now, even though we are currently estimating that positive variance at the end of the fiscal year based on current projections, I do want to add a few caveats. Firstly, we typically hold some money aside, usually $225,000 or less, for late arriving charges from control agencies. Second, the negative variance in operations reflects a strategic reallocation of salary savings, not overspending. We closely monitor expenditures and we use the salary savings as we are realizing them for contracts that are timely, such as the strategic planning update or the language translation agreements that were mentioned in today's announcements. I want to stress that contracts will continue to either be listed on our announcement slide or presented for official expenditure authorization to the Commission. The pie chart reflects the year-to-date column from the previous slide. It is designed to visually represent the categories of expenditure and the percentage each contributes to the Commission's overall state operations spending. Salary is 51% of our operations spending, benefits 26%, and the less than a quarter remaining is divided up between facilities, IT, procurement support, supplies and goods, travel and meeting expenses, legal, and other miscellaneous little contracts. Moving to the local assistance allocations for fiscal year 2025-26, our Mental Health Wellness Act grant has not had any year-to-date expenses. The funds have been encumbered or designated for the grants, and there is no variance between the budget and the estimated total. Similarly, our Behavioral Health Student Services Act funds have been encumbered and no funds remain to designate. We are in the midst of the community advocacy funding for this year. We announced the award of the TAY at the top of this meeting during the consent item to Pro Youth and Families. So that's going to take care of the amount that you see in the designated column, so there'll be no projected variance for that category. So altogether, local assistance reflects a budget of $34,306,000. Year-to-date expenses are $273,747. We have a remaining encumbrance of $17,943,476, and the rest of the balance is designated. So we estimate that there will be no variance let's see, yeah, I already covered that. We're going to skip ahead. So this slide summarizes other active local assistance funds from previous fiscal years. Our MHWA grant for fiscal year 2024 is entirely encumbered or designated, with about $13 million encumbered and $6 million designated. These funds include our 0 to 5 maternal behavioral health technical assistance contract with the Public Health Institute and the FSP Performance Management Technical Assistance contract with Third Sector Capital Partners. We have 3 line items for the Behavioral Health Student Services Act, each of them with no projected variance. We are on track to spend and encumber all of these funds. The older adults reappropriation has nearly $500,000 encumbered and about $250,000 designated. There is a projected positive variance for these funds. However, this program and these funds are sunsetting on June 30th, 2026. We have added the funds to any of the grantees who had requested additional dollars to complete their scopes of work under the grant. And then due to the timing constraints for approvals, there should be no other redistribution of the positive variance. I also wanted to mention that the current reversion date for the ALCO funds is June 30th, 2026. We have a current request in to extend the liquidation date of these funds to June 30th, 2027. We expect that if that is signed by the governor, that it would be part of the 2026 budget and allow grantees additional time to complete site development and staffing. So altogether, the prior year's active funds reflect a budget of $242,641,301. Everything is on track except for the positive variance. Well, it is on track. It's just we can't do anything with it of $261,438. So that concludes the brisk mid-year budget update. Thank you for your time and attention. I want to remind anyone watching that you can always email budget@bhsoac.ca.gov with questions, ideas, or feedback. I'm going to kick it back to you, Chair Roulette, for commissioner comments and questions.
Thank you for waxing poetically fiscally. All right, we'll start with Commissioner Alvarez and anyone on this side of the room. Any questions? Seeing none. Over on my side, no. And on this side, no. Thank you so much. Cody, in the absence of Amariani, is there any public comment? Nope, I see one public comment. Cody, are you able to help?
Yes, Chair, I'm able to help out. We have one public comment. Steve, please go ahead.
Hi, this is Steve McNally. Thank you for allowing public comment. I want to thank Commissioner Madrigal-Weiss for attending or visiting the Alcove in San Juan Capistrano. And the LA Board of Supervisors, which you all may or may not be aware of, has asked DMH to come back with a plan to fund the current alcoves and future alcoves within their city or county area. So I'm not sure how that might adjust the alcove funding, which alcoves are incredible, but they're super expensive versus declining enrollment and finding space on campuses. Santa Ana Unified has a wellness centers in every school in their district of varying sizes. And so it ranges. And the one thing they have that's, I think, incredible, just like the presentation you saw today when people are centered, is they come with a liaison that takes the pressure off the student to explain to their parents because there's a family liaison. Thank you.
Thank you, Cody. I think that is the end of public comment. Thank you, Lauren, and thank you, commissioners. Thank you again for that poetic fiscal report.
I'm sorry, Chair, can I ask just one question?
Oh, certainly. Lauren, you might want to come back.
In the notes, there's a lot of, these are done in 2026. This one's finished in 2026. At some point, it would be helpful to understand either the reappropriation of these funds, right? Because a lot of this is what the commission does and what we're known for, and what is the future of these funds given the uncertainty of the budget? And I don't know if you're ready to answer that now, Lauren, but just something maybe for a future conversation, just as far as our role as ambassadors of the commission.
What I can say is that at the next BFA on April 16th, we are going to have an enhanced handout where we're going to list every single active contract, and there's going to be a lot more information for each one. So, and it will then be posted on the website. So hopefully that will answer some of the questions and create a platform for even deeper discussion. We really go in BFA, like we really dig in there, especially Pulmano, man. She puts me to task every time with those real good questions. So, which then translate into written materials that we will post.
Can I say something really quickly too, just to add on to what Lauren said is, like, all of these are our annual appropriations, so barring any changes through the budget process, all of these are our ongoing appropriations. So even though it looks like it's ending, that's just that cycle of contracts would be ending. So that's why we have these discussions at the commission meetings for like our ongoing Mental Health Wellness Act dollars, which we'll be talking about tomorrow, and so, you know, planning for future allocations. And so, but all of everything that Lauren talked about, I think pretty much all of it's ongoing funding, although some of the Student Services Act funds, those come down. So we had that big balloon of the BHSSA dollars.
And then just the annual.
And then we'll have the annual allocation of, yes.
7.606 million.
Yep, exactly.
Exactly, annual, yes.
Thank you again, and Commissioner Alvarez, we'd love to have you at our BFA meetings. All right, let's move on to agenda item 10. This is the Public Advisory Committee update and recommendations. As many of you know, the Commission has a long history of using data to drive transparency, accountability, and transformational change in California's behavioral health system. First released in 2017, the Transparency Suite is a part of the Commission's dedicated effort to improving transparency around mental health funding, programming, and outcomes. Dashboards within the suite provide visualizations on data for county programs under the BHSA, criminal justice involvement, full service partnerships, disparities in mental health care, and more. We are now going to hear from Melissa Martin-Millard, Acting Deputy Director of Research and Evaluation and Programs, and Gary Tsai, who will also be providing comments and input as part of this presentation. Melissa and Commissioner Tsai, please.
Thank you, Chair. I'm just going to frame a couple elements prior to Dr. Martin-Millard's presentation. So this item really focuses on the Commission's data strategy and its role within California's broader behavioral health transformation. As you know, the Commission is one of various partners responsible for upholding a data-driven approach, ensuring that decisions, investments, and outcomes are grounded in transparent, actionable information. In February, the Commission's Program Advisory Committee dedicated its meeting to focus on data, particularly around BHSA and how it elevates the importance of data for planning, monitoring, and system improvement. At that meeting, the committee heard a very informative presentation from Anna Knifey from DHCS, Department of Healthcare Services. She walked us through the statewide work underway to establish clear data goals and an accountability framework for behavioral health transformation. As part of that work, she described how DHCS is bringing together various partners, including counties, providers, people with lived experience, to identify data sources and measures that can inform local planning, track performance, advance equity in behavioral health access, quality, and outcomes. Building on that, the committee then received a presentation from the Commission's research and evaluation staff. They highlighted the Commission's analytic framework and data capabilities, and how that work complements the efforts of DHCS as well as other state partners. Staff described how the Commission's data initiatives bring unique value to California's broader behavioral health landscape through the planning and evaluation of grant initiatives, legislative reporting responsibilities, as well as public-facing dashboards that illuminate trends in funding, service utilization, as well as outcomes. And so today, staff have been invited to present this framework to the full commission. So the PAC had a bit of a preview. As the commission adjusts to its new structure and roles under BHSA, this is a helpful opportunity for us just to revisit our data strategy and consider opportunities to strengthen how we meet our statutory responsibility to support data-informed transformation within our behavioral health system. And this presentation will expand on what was shared at the last PAC meeting. So with that, I'll turn it over to Dr. Melissa Martin-Millard.
Thank you so much, Commissioner Tsai. Okay, so our goals today, as Commissioner Tsai indicated, are to walk you through and continue the conversation that we started at the Program Advisory Committee, and inform and remind you all about the roles and responsibilities under BHSA as it relates to data, to describe how data informs the Commission's work, review our capabilities and current portfolio, and then to end on some discussion and reflection around how we can better fulfill our responsibility to serve BHSA priority populations and respond to the ever-changing behavioral health landscape. Okay. So I'm just going to, in the interest of time, go over the next few slides rather quickly, but just to give a broad overview of our data uses and data types. We get data from a variety of sources that can be used to identify and describe behavioral health needs, including factors that contribute to risk and disparities, point to promising solutions and assess barriers to implementation, and measure outcomes and impact for individuals, communities, and systems across the behavioral health continuum. We also use data insights to guide our resource allocation, promote evidence-based practices, and inform strategies to reduce disparities. And so data really is a core component of our transparency and accountability work, really grounded in the equity focus. I want to just take a second to point out that under the BHSA, we do have some pretty well-defined statutory requirements. So data and data work is really central to our role under BHSA. The BHSA was established to promote transformational change in California's behavioral health system through research, evaluation, and tracking outcomes, and other strategies to assess and report progress. There's language in the statute about using information and analyses to inform all of our work, but to lift up key policy issues, emerging best practices, provide technical assistance and training, and promote high-quality programs while also advising the governor and the legislature. Okay, so our kind of the way we think of our data framework is that data is used for these four kind of buckets. So we use data to engage, inform, plan, and evaluate. So our engagement looks like partnering with other stakeholders, community members, working with our state agency partners to make sure that our efforts aren't duplicative, but rather are additive and helpful to the public and other partners. We also use data to inform and promote transparency. So we really see data as an important lever for identifying and describing trends related to behavioral health risk, service access, outcomes, and disparities. We've also, through our transparency suite, used data to track spending, to make policy implementation recommendations, and point out opportunities for improvement. We also use data to plan. So for our extensive grant portfolio, we try to ground our RFP and RFAs in data and where our grant dollars and local assistance dollars will make the most impact based on data-driven decisions. And then lastly, to evaluate. We also want to know, how did our grant dollars and local assistance dollars work? What was the impact? What did we learn through implementing pilots and oftentimes new projects and strategies across the state? Okay, so I'm going to now spend a couple of slides moving into our data capabilities. I'm going to just skip this slide because this is more or less a recap of what I just talked about. So I'm going to go into our data warehouse, which really is a unique feature or a unique strategy that we have at the Commission to be able to look at individual level data for children, adults, people who are touching the behavioral health system in some way. We are able to match that data to data from other state agency partners to better understand outcomes like hospitalizations, criminal justice involvement. I do want to share that just this past week, we were able to get data from our partners at DOJ. So this will allow us to do a lot of different analyses, including update our current criminal justice dashboard that looks at arrests and people who are in a full service partnership. So this, you can see kind of the array of data we have. We also get hospitalization data from HCI. We get vital statistics from CDPH. So again, these allow us not just to look at kind of utilization trends, but really allows us to look at various outcomes for individuals receiving services. And some of this work you'll see reflected in our reports to the legislature, like our full service partnership report that we submitted last year, has utilized this tool to be able to track psychiatric hospitalizations for partners who are in a full service partnership. Okay, in addition to this amazing resource we have in our data warehouse, we also get a variety of data from other sources. So anytime our staff works on a policy project or plans for a grant opportunity, we really are going out into the community and doing focus groups, listening sessions, key informant interviews, and that counts as data. We want to hear directly from the community, including those with lived experience, about what's most important to consider when we're putting together, again, policy recommendations or an RFP or an RFA for local assistance dollars. So the point is that there's a variety of both quantitative, so like the numbers and the hard data, as well as the qualitative information that we consider as part of our full data portfolio. Okay, the Commission has maintained a what we call our transparency suite. So we maintain a variety of dashboards and have really been working hard. Our data team has been working really hard to produce some additional data dashboards that we have some plans for dissemination. So this is kind of an overview of what we already have on our website under the Transparency Suite tab. So we have our fiscal transparency dashboard. That includes funding and expenditures by county behavioral health departments. It's updated through fiscal year 23-24. Now that we've shifted into BHSA, we're going to be updating with our 25-26 revenue and expenditure data when that's available. We also have a disparities dashboard that compares demographic information of people receiving publicly funded mental health services to the relevant Medi-Cal population and population in California in total. And those comparisons are made statewide and by county. There's several others, including, I know we've spoken in various ways today about suicide. We do have a suicide incidence dashboard that is really allows you to go in and again look at county comparisons, compare counties to the statewide average. So just highlighting those dashboards that already exist on our website. Okay, let's see. Okay, so we are also developing some policies and internal procedures to make sure that our data and our dashboards are valid so that the information is accurate and correct, that the dashboards are relevant so that they are a tool that are helpful for the public and other stakeholders, and that they are inclusive, meaning that we've really gotten input and feedback from the public and stakeholders to make sure that the information, again, is helpful and relevant, and that the tools are easy to use as well, so that they're accessible. So all of our products that are public-facing, our dashboards, are really vetted by our key partners to ensure alignment with BHT goals and priorities. Some of our partners include DHCS, CBHDA, HHS, and then for the state agencies from whom we receive data, we're always having meetings with them, so Department of Education, to make sure that we're aligned and that we're not producing and pushing anything out that hasn't been fully vetted and approved. One thing that I want to just take a second to respond to, I know Commissioner Bear, at our Program Advisory Committee meeting, you had some really excellent questions about data security and kind of our use of AI. So I wanted to take this opportunity to respond more fully to those questions, because I think they were really important to bring up. So one of the questions was around our data security and whether we were potentially vulnerable to federal agencies requesting our data, since we do have individual level data, that we might be vulnerable to a federal request. And so we did some research and talked with our data team. So a couple of points to just highlight is our data center, our data warehouse is very, very secure. We adhere to strict data security standards established in our interagency data use agreements. Because we also house criminal justice data, we have the FBI's criminal justice information security standards across the board for all of our data. So this is, the strictest kind of data security measures that can be put into place. We also, in terms of vulnerability for any data requests from the federal government, because our data is all secondary data, the individual level data we receive is all secondary data, we don't really think that the commission would be targeted for a federal data request. If in the unlikely event that that our data was subpoenaed, we would defer to policies upheld by the original owners of the data. We did speak with several of our state agency partners, and confirmed that generally speaking, federal agencies cannot legally request data for customs or immigration enforcement purposes. So we're continuing to engage with data partners and monitor and stay up to date with the evolving data security climate. Okay. So I want to now take a couple of minutes. I've been speeding through this because this is what I'm most excited to share with you all. The team has just been working, like I said, extremely hard on a couple of new dashboards. So these are not publicly available yet because we haven't completed our data dissemination steps to make sure that we've gotten that thorough vetting by state agency partners, that we have a public input period, and of course have a chance to sort of socialize these with you all and get input and feedback. So I'm going to switch over now to the population behavioral health measures. Okay, great, there it is. Okay, so this is our landing page. So there's some information about the population behavioral health measures and what they are. Then if you scroll down, we have dashboards for each of these areas. So for our goals for improvement, we have access to care, care experience, engagement in school, work, prevention for co-occurring conditions, social connection, and quality of life. And then on the goals for reduction side, we have dashboards for homelessness, institutionalization, justice involvement, overdose, removal of children from home, suicides, and untreated behavioral health. So because, again, we spent some time, the caring moment was focused on the nets on Golden Gate Bridge, and we've heard some other discussion around some of the work the Commission's been involved in for suicides. Let's see if I can get this. Okay, that was a lot of pink. Okay, so when you click on each of the tabs, you get this kind of overview of the measure, and then there can be sometimes only one dashboard associated with the measure. Other times there's 4 or 5 different dashboards. So I'm going to focus first on just the dashboard for deaths with intent to suicide among Californians, age 10 to 119 years of age. So this is all measured in terms of a rate per 100,000. So this top graphic shows the dotted line is the state median rate, and then the stars are the county that's selected. And so you can use the drop-down menu to look at Sacramento and see Sacramento is kind of in line with the statewide rate. Then if you scroll down and look at our heat map, you can really see very visually and very immediately which counties are struggling the most with their suicide rate per 100,000. Amador County has a rate of 35 per 100,000. So the darker the orange here in the map, the higher the rate is. So you can really see that the superior region counties tend to have the highest rate of suicide in the state. When we're able, we also disaggregate by race, ethnicity, and age. So you can also take a look at these trends by these demographic factors. And then I'm also just going to point out for the non-fatal self-harm indicator, for this one, what really stands out to me and just breaks my heart and is a lot of why I do this work, is if you look at the age range, it's the 15 to 19-year-olds who are, they have the highest rate for any age group. So all the work that's happening across the state for suicide prevention efforts, for all age groups, but particularly for that 15 to 19 age group is time and resources well spent. I'm just going to go back to the measures again and also look at overdoses. So for this metric, we have drug-related overdose deaths. So again, same kind of format where you can do the drop down by county, compare it to the statewide rate, and then see overdose deaths, again, the rate per 100,000 for each county across the state. And again, this is one of the measures. We can't disaggregate by race, ethnicity, and age for all of our measures, but for this one, we're also able to do that by first by race and then by age group. So this is just a sample of the measures and just kind of a preview. I'm going to turn now to the second one that the team has been working on. And this is a really good example of the work that the data warehouse allows us to do. With this dashboard, we linked the children who were receiving any CSI service or any behavioral health service, and then the subset of those children receiving FSP services. We linked that list to our education data. And so with this, we're able to see, to do all these comparisons for educational data. So chronic absenteeism, dropout rate, suspension rate, graduation rate, and then language and math assessment scores, whether the standard was met or exceeded. And so the first kind of blue bars that you see, that's all of California students, everyone. And then the orange bar that you see is the children or students who have a CSI service within the past year. And then the last bar in each of these, for each of these indicators, is our kids receiving FSP services. So you can see for every single indicator, the kids receiving FSP services have worse outcomes compared to the general population of kids, and even compared to kids receiving behavioral health services. So again, we have the heat map and then indicators here that you're able to look at. This one is for the chronic absenteeism, looking at the trend over time. Okay, so I think we can go back to the slides now. Sure, please, Commissioner.
Could I just ask a question?
Yes,
do
please.
those charts also have the standard for what constitutes chronic absenteeism? I wasn't able to read the chart. Are those on there? What the standard is for what is chronic absenteeism?
I don't think we have that. Usually we let me see. Sometimes we have pop-up windows that do explain that, but this is exactly the type of feedback that we would want, so that it's very clear exactly what we said, what constitutes.
Yeah, especially where we're getting into the education space rather than.
Absolutely.
Yeah, thank you.
Absolutely. Okay, I'm just,
Melissa, I think there's a couple of comments that, and
Yep.
part of what we've committed to do is allow commissioners to ask questions as you're doing the presentation. And
Sure thing.
so, and Commissioner Tsai, thank you so much for saying yes. Both of you are prepared to answer some of the questions that come up. So I'm going to start with Karen, and then we'll just go this way. Okay.
First of all, I know it's hard being the girl standing between us and lunch, so A+ for getting through and getting us closer to on time. I love data, and I'm a total nerd about this, so I love everything you showed us today. And I think one of the things that came up for me when you were talking about the data warehouse, and as we move into like focusing more on priority populations, if there might be an opportunity for us to get some of the CDSS data for child welfare youth or juvenile justice involved youth, you know, some of the populations we're missing, there's a big hole in that data warehouse around people experiencing homelessness. And so would just love for us to explore ways to partner with additional entities to get that other data. And just any way we can pull out those priority populations. I love the population health level data, but they really aren't at the level where we know, how are we doing when it comes to people experiencing homelessness, incarceration, you know, hospitalization, all of our priority populations.
Right. Yes, absolutely. We have several state agencies on our list to work with and pursue data use agreements with next.
Okay. Commissioner?
Thank you for the presentation. Prior to the meeting, I actually went to the website and looked at the different dashboards that are available and just played with the data. I particularly liked the key findings and the highlights reading them. And I have to predicate my comment really on the fact that I am not really good at numbers, at charts, at graphs, data. I like written words that has to go with the information. Mm-hmm. So I think my comment today is I would like to see an improved utility. How do we improve the utility and value of these reports to people like me that are not very good at looking at numbers or dates and graphs, charts, what have you? And not just me, but you know, researchers and members of the public. And for example, you had indicated that you know a lot of the data we use for reports like the full service partnership report to the legislature. But everybody, let us look at this report. Even for a legislative staffer like me, this is going to be a long read, and I have to invest in it in the limited time that I have. So what I am thinking is something that HCI actually does with the health payments database that they have, and they produce public reports. Mm-hmm. And I don't know the capacity of our team here, but it could just be an addition to the key highlights and the in findings that you have currently there now. And I'll give you an example of the questions that popped in my mind as I was looking at this. Mm-hmm. For example, on the fiscal transparency dashboard, which counties are, you know, spending their money consistently from year to year? Which counties are lagging? Do we have information as to why they are lagging? Where are these? I know you have, you know, some of the areas where they spend their money on, but I think really more like providing a summary of those things would be helpful to people like myself. Another example, the client services dashboard. There were, you know, would it be helpful to have the percentages who have serious mental illness, severe emotional disturbance for children? What are the services that are mostly used? What are the primary languages, for example? I think you have some information there, but maybe a little bit more granular. And lastly, another example that I actually looked at is the criminal justice dashboard. Mm-hmm. I think your arrest includes arrests, age group is also included, but I do not know whether this data is included, is how many of these arrests are because they are unhoused, for example. And really looking at, you know, patterns and the utility of this information that we are collecting, we have to make sure that not just us and the staff are able to understand, but really more on the public side. And I again use the example of the health payments database as HCI because, for example, they have done short reports, for example, drug cost reports, and that is really an example of, I think, what we could do more with these reports. Thank you.
Thank you. Yes, Commissioner Tsai.
I know I'm supposed to answer or respond to comments, but I actually have a couple of comments myself. Similar to Commissioner Larson's comment, and I mentioned this during the PAC, but just because we have a different audience here, I think that the DMHC, Department of Managed Healthcare, is another entity at the state level that would be helpful for us to get data from and understand, just because there are considerations around how commercial insurers are performing and how they're covering services and actually delivering services that actually have influences on the public side that we would be interested in. And the second comment is around on the transparency suite. I didn't see the box. I see the box for suicides. I didn't see the box for overdoses, but if we could put that there, I think that would be helpful, just because when I think about behavioral health, mental health and substance use, suicides are kind of one of the key things we focus on the mental health side. Overdoses are one of the key things that we focus on the substance use side. And then the last comment is just around data security. And it's a little bit less applicable, I believe, because the data that you're presenting here isn't individual level data. Is that correct? It's more kind of in aggregate. But one thing for everyone is, we have HIPAA that governs confidentiality for all health data, and then 42 CFR Part 2 that governs confidentiality for certain substance use entities. And in general, Part 2 has been more restrictive. Yep. But as a result of some rules that were issued in 2024, it's now better aligned with HIPAA, which does allow for better data sharing. And in particular, it allows for redisclosure. I think that's one of the reasons why I want to share it, is, entities that have Part 2 or SUD data are able to redisclose it now, assuming that there was initial client consent. However, my comment is around, I think we as systems, particularly as we share more SUD data, need to recognize, number one, the criticality of providing informed consent to clients, so that when they sign universal release forms, which will soon be the norm across California, they understand what some of the certainly the benefits, as well as what some of the potential risks are. And I think in systems where most of the healthcare providers I speak with don't know what Part 2 is, I think it's hard to ensure that clients have informed consent if they don't know what Part 2 is, because they can't talk about it. They don't know what the implications are. And so, from my vantage point, being conservative, at least in these early years of broad data sharing around substance use data, recognizing that people do still lose jobs and kids, and sometimes are criminalized as a result, would be wise. And so sometimes things that are legal, right, because it is legal in terms of redisclosures with Part 2, aren't necessarily advisable, right? And so I just wanted to comment on that, but thank you very much for the presentation.
Let me start with Commissioner Contreras, and we go this way.
I have a comment, but it's on the consideration slide, which I know you didn't get to. So
it's okay.
It's okay. Okay. So first, thank you. As a newer commissioner, I can acutely remember how impressed I was when I arrived about seeing the commission's capability and expertise around data infrastructure and evaluation. So it's amazing. I have a question, because your consideration slide sort of asks and points out, like, hey, there's a lot of goals around BHSA that require mandates around reporting, right? And as I think about the data life cycle, what I'm seeing on the ground in communities is that the sort of pressure to meet those mandates are pushed down to providers and to county departments, right, that don't have a lot of infrastructure around data, or are really good at data quality. So I'm just wondering, from your vantage point, does the commission have a role around technical assistance for CBOs or county departments? And if we do, what are we doing now, or what could we be doing to sort of help around that?
Yeah, I think that's a great question, and one we've been trying to figure out is how can these tools be used to support the county's planning process? Is it data in real enough time that it will be helpful for planning processes? I do think, within the statute, the commission does have a technical assistance role. I don't think it specifies directly that role be for providers, but certainly to county behavioral health departments. And I think we are wanting to initiate this conversation at the PAC and the full commission to get your input as well on what would be helpful on the ground. How can we design our dashboard tools to be effective and useful for providers, the community, county behavioral health departments, et cetera?
I don't have any great ideas, but that's why I asked.
Yeah.
But I think this is a real important one, because I think especially the data going into these systems and the requirements, just take Cal-AIM, for instance. I know a lot of counties are struggling with how to input stuff into HMIS, how to build that out. So I think it's an important sort of topic to continue to mull over how the commission can really help at the ground level around that.
Absolutely.
Thank you.
Thank you.
Right. Commissioner Brown?
I just wanted to comment also that we got to be careful with the data, with the not only with the fidelity of the data, but also how it's examined and how it's used. And it's particularly the case in criminal justice. And Ms. Pulmano's comment about how many of these arrests were made because the people were homeless. It's very difficult to say because there's so many other factors, mental health issues, substance abuse issues. We can track how many arrestees are homeless, but we can't really say if the underlying crime was really caused by homeless in a quick and easy statistic. It's not easy because the cases are so different. Similarly, we're oftentimes asked, how many mentally ill people do you have in jail? And it's not easy to determine that because historically, we used to say, okay, how many people do we have in jail that are receiving psychotropic medication from our mental health and our health staff while they're in jail? But now we have a very robust medication-assisted treatment program that provides buprenorphine, which is a similar type of drug, is classified as that drug, and we can't use that really anymore because we don't know. Many of those people that are getting buprenorphine could indeed be mentally ill. Certainly, they all have some kind of substance use issue, but it's hard to find data points that are really indicative of underlying problems and issues. So it's just, I just say, well, we have to look at that, and that's just in criminal justice. I'm sure if you look at it from the standpoint of, as you said, housing, as you say, all these other factors where maybe somebody, it's not just if somebody has a house, it's where do they live, if they're in that rural or frontier, is it very different than if they're in an urban setting and so forth. So we just have to be careful with that.
Okay, Commissioner Bontrager.
A quick question. Do you have access, or do we have access to the new DHCS's Medi-Cal Connect Population Health Data Warehouse?
That's not ringing a bell. Is that, I'll have to look into that. I'm not sure.
Yeah, because it has social services information, physical health information, justice involvement info. It might be good for us as a commission.
Is that through the open data portal?
No, they have a master data sharing agreement, kind of like through the interagency data sharing agreement, that they've pulled all the data together from different agencies, and then they're able to post it on Medi-Cal Connect. So,
but I would think
we haven't tapped into that.
I would think we could have access to that.
I'm hearing from my team is miming to me that we are we're in talks with being able to get access to that data.
Okay. Very good. And then the second comment I have is, I hope, because I think too often we chase deficits, just generally speaking. I would hope through these dashboards, if we find a bright spot where a county is doing something well, we amplify it and we have them come and share what they're doing well so other counties can learn from it. Because I'm a firm believer you get more of what you pay attention to. We need to pay attention to what's working too. So.
Thank you.
Great point. Commissioner Gordon.
Yeah, I couldn't agree more with your comment, and I think the presentation we had earlier is a great example of questions we could ask of the data, which would be revealing things that are being done well in particular areas which we could capitalize on in terms of our technical assistance, et cetera.
Seeing no other commissioner comments? Melissa, I'll let you, I don't know if you had a chance to wrap up your.
Just super, sorry. I thought.
I say maybe next steps so that, one slide back so that folks know
Yeah,
kind of our next steps and then public comment.
Yes, exactly. So just by way of concluding, we are in the process of first working with our state agency partners on the dashboards that were just presented to make sure they've had a chance to provide input. Our step after that is to basically do 1 month public releases so that we get input from the general public. We'll certainly make sure that we push out these dashboards during the review period to you all for input and feedback and suggestions. We'll make revisions based on the input and feedback we receive, and then publish and make sure that we are reviewing them on an ongoing basis to make sure that the data still is complete, up to date, and we'll take all of the suggestions and ideas back to our team to continue iterating, and I'll conclude there. Thank you so much.
Thank you, and thank you, commissioners. I'm going to move now to public comment. Mariani, if you could, please.
We currently have 2 public comments. Our first comment is from Laurel.
Good morning again. Very interesting. In fact, I'm probably going to listen to it again. So when the Little Hoover Commission reviewed the MHSA after a number of years, they liked what they saw, but they couldn't really base an opinion on it, they said, because the data that had come in from counties in particular was poor or non-existent. And I'm sure that was a big frustration to the MHSOAC staff at the time as well. I wonder if you're finding in Prop 1 and the other parts of the changes in healthcare, if there are incentives now that might remedy this situation. I think the state hesitates to punish counties for obvious reasons. And then my second question would be, what AI products, if any, from which companies are you using to analyze data and maybe help you produce these wide variety of dashboards? Thank you for your work.
Thank you, and as always, the commission staff will provide answers to those questions, not just to the person who asked them, but to everybody. Thank you. Back to you, Mariani.
Thank you. Our next comment is from Teresa.
Hi, Teresa Comstock again with CalBHBC. I just wanted to remind you that the 59 local boards and commissions have a duty to comment on performance outcomes to the California Behavioral Health Planning Council. So, having the collaboration of all of CalBHBC, CBH, and the Planning Council, I think is important in order to really leverage the comments and recommendations of the boards and commissions and to get them to look at this data. So important to make it user-friendly and printable for public meetings so that there can be accountability and review on the local level and then the communication to the state level. Thanks.
Thank you. That was our last public comment.
Thank you, Melissa, and thank you to the committee. Commissioner Tsai, thank you so much. And look forward to your responses to some of the comments that were made today, and obviously this is an important topic area. We're now going to move to agenda item 11, lunch and closed session. For agenda item 11, we will pause to allow commissioners to grab lunch and to enter closed session to meet with legal counsel per California Government Code Section 11126E to discuss pending litigation matters. Before we move to closed session, we will take public comment on this item. Amariani?
We do not have any public comment for this item.
Thank you so much, commissioners and members of the public. A reminder to our virtual commissioners to please leave this meeting and join the closed session via the Zoom link sent by commission staff. It will say closed session Zoom link with today's date. We'll return at 1:16 to establish quorum and report out from closed session. Thank you very much. See you back here at 1:16. Like to reestablish quorum, so if all commissioners could return to your chairs. I know that you are so excited. We had birthday cake. Thank you. Thank you, Brenda et al. Staff. Thank you so much. On behalf of Commissioner Thomas Beckett and myself, who had birthdays. Yeah. Special shout out to Aurora, Colorado. My dad is having a birthday on Saturday. He'll be 90 years old. Thank you so much. There you go, Dad. You made the agenda. Yeah, the 90s. He wouldn't agree with that. Okay. Agenda item 12, we reestablish a quorum and report out from closed session. Again, hello everyone and welcome back to the meeting. Thank you so much. We all returned at 1:16. You all are awesome. I hope you enjoyed your lunch. For those of you who joined us online, first I will ask Sandra to please reestablish quorum with Commissioner roll call.
Thank you, Commissioner Roulette. I'm going to start calling quorum. If any commissioners are joining us online, please unmute your line to expedite the process. Commissioner Alvarez.
Here.
Commissioner Baer.
Here.
Commissioner Burnick, marking absent. Commissioner Bontrager. Commissioner Brown. Commissioner Bunch, marking absent. Commissioner Callan.
Here.
Commissioner Carnevale, marking absent. Commissioner Contreras. Thought he was here. Marking absent. Commissioner Designee Swartz. Marking absent. Commissioner Cross.
Here.
Commissioner Fairweather. Here. Commissioner Fernandez.
Here.
Commissioner Gordon. Here. Commissioner Designee Pomano. Commissioner Hill, marking absent. Commissioner Larson. Here. Commissioner Madrigal Weiss. Here. Commissioner Mitchell, marking absent. Commissioner Robinson. Commissioner Southard, marking absent. Commissioner Thomas Beckett. Present. Commissioner Sy.
Here.
Commissioner Wilkes.
Present.
Vice Chair Chambers, marking absent. Chair Roulette.
Present.
Thank you,
Thank you, Sandra. I want to provide an update on what action was taken during closed session. No action was taken. There was singing, but there was no action taken afterwards or during the song. All right. Next, we're moving on to agenda item 13, update on strategic plan refresh. The Commission's 2024-2027 strategic plan to align with the Behavioral Health Services Act and priority populations. We will hear from Executive Director Brenda Graylish, Committee Chair Karen Larson, and Committee Vice Chair Brandon Fernandez, and also present are Eric Douglas and Karen Bloomer from Leading Resources Incorporated. Going to ask Brenda to lead us out in the presentation, and thank you all so much, and thank you to our committee chair, Commissioner Larson. We appreciate that, and Commissioner Fernandez, we appreciate you. Thank you.
Thank you so much, Chair. Brenda Graylish, Executive Director. I'm very excited to move this work moving for our strategic plan update. We had our kickoff back in January of 2026, and so many of you were here to help get that started. I just want to maybe open it up really quickly for LRI to say a quick hello, maybe, so that you guys can.
We're glad we're here and looking forward to the conversation. This is Eric Douglas.
Yes, thank you so much. Karen Bloomer with LRI.
Thank you. So I'll just hop right on in. In terms of today's meeting, we have discussion on the scope and approach to our strategic plan and like an update on it. I'll give you a little refresh on kind of where we've been, where we're going, and then talk to you about our proposed priorities and results that we are working on we're proposing for the next couple of years. And the goal of today's presentation will be to A, put it on your radar so that you kind of know where we're at in the conversations, and B, to get your input so that it can continue informing our conversations as we continue thinking about our strategic plan update. So in terms of how we got here, this is a slide just, we talked about it at our last meeting in January, but we did our 2024 to 2027 strategic plan that is now available and on our website. That was done before Proposition 1 passed by the voters, and so what we're working on here is not a full strategic plan update. We will do that probably starting next year, but for right now, just to get us focused on the BHSA priorities, we're working on doing kind of an update or an addendum to our existing strategic plan. So BHSA is well underway. We started that back in January. We've got our name change, all of our new commissioners here with us now, and the state's been preparing for BHSA implementation with the counties and providers. So just in terms of some table setting, just recalling from our January presentation that 100% of our funding here at CBH is from the Behavioral Health Services Fund. So we are 100% funded by that fund right now. And again, like I mentioned, we have this time-limited strategic plan work that we're doing. We established at our January meeting our Strategic Plan Advisory Committee. And we've got LRI on contract to help us work through and do a lot of facilitation of these discussions, helping us capture the information and compile it in a way that will lead us to our addendum, our final product. So in terms of the timeline, it's again moving very quickly. From January to May is when we're looking to gather all the information through our Strategic Plan Advisory Committee, plus these commission meetings to inform our final work product, which is our update. And then we will, we've already had the initial discussion at our January meeting. The Strategic Plan Advisory Committee met in February, continued to take that feedback from the January meeting, work on it even more, and trying to flesh out some priorities and results that our commission can focus on through the rest of fiscal or through the rest of calendar year 2026 and on into calendar year 2027. After this, I will get our information and more feedback from all of you today that we will then take to our April Strategic Plan Advisory Committee meeting, and then we'll continue to work on the final results and priorities for the final paper, which we will then bring back to the Commission in May of this year at our full Commission meeting to present it to all of you, all of our commissioners to adopt it. So that's the goal. And then once it's adopted, if it gets adopted, then we as a staff commission, CBH staff team, along with LRI through LRI support, will work on developing an implementation plan so that we can then start tracking the work that we're doing to meet those results and priorities, or priorities and results, I should say. Just a little reminder here and a big shout out and thank you to our commissioners who had volunteered to be on our Strategic Plan Advisory Committee. The committee is chaired by Commissioner Larson and vice chaired by Commissioner Fernandez. And we also have as committee members Commissioners Brown, Callan, Carnevale, Fairweather, Thomas Beckett, Sy, and Wilkes. So appreciate everybody, again, volunteering for that and showing up and providing a lot of really robust feedback when we had our February committee meeting. In terms of the committee charter, again, we're not looking to do a whole new strategic plan. That'll be the next step after that. But for now, this is our update or refresh of our strategic plan through the lens of the Behavioral Health Services Act. So that's another thing to keep in mind today as we talk about this strategic plan update, is that we're really looking to think of our projects through that lens. Some highlights or some recaps of what happened at the February committee meeting. The committee had endorsed retaining the existing strategic plan goals and objectives, so we're not looking to change anything. Again, this is kind of like an overlay or an addendum. Again, we're looking at having a lens of these priorities with some desired results for each of those priorities that are reflective of the Behavioral Health Services Act, and say how we're going to work on these priorities and results in the next through the end of 2027. Some of the work that we were doing as we've been kind of thinking about it, we're looking to align our existing work that we have within our portfolio. So we didn't approach it with the idea of adding more because we don't have new resources, but trying to think about the resources that we have. What are we currently doing that aligns with the Behavioral Health Services Act? What might wind down, and then also what might ramp up? And so again, like I said, we'll be looking to get through this update through up to the summer times, and then we'll work on that, but probably in the fall or early next year, sometime in the winter, we'll start conversations about a new strategic plan that would begin in 2028. Okay. Some of the other things in terms of, as we've kind of gone through our results, our priorities and results, our draft priorities and results, some of the key points that came up in conversation that we thought would be helpful for all of you to be aware of is really highlighting the full continuum of housing options, housing being a big part of the new allocations for the Behavioral Health Services Act, and the importance of really thinking of that full continuum of housing options. Thinking of substance use disorders as a standalone as well as a co-occurring condition. We tend to lump it all together when we talk about it, but we really need to really think a little bit more granularly, because these are different populations, and each one really has unique considerations. Also addressing not just substance use disorder treatment, but the full substance use service continuum, so things like prevention, harm reduction, treatment, recovery housing, so things that maybe our commission hasn't really had to dive into before, but just things to think about as we talk about our priorities. As you might recall, substance use disorder is one of them. And then elevating the essential role of peers and the role that peers play in the success of behavioral health services. And that is, again, one of our priorities, which I will dig into those priorities next. So in terms of the priorities, again, these would be our priorities through the rest of calendar year 2026 on into 2027. We'll probably inform what we do afterwards, but these are going to be our focused priorities during that time period. Priority one being meeting the needs of people with the highest behavioral health needs or conditions in the state. And the rationale for this is really that this aligns with the 14 BHSA goals and the priority populations. Also that it includes housing issues, that it's a link through housing issues. We as a commission already have a statutory mandate for full service partnerships through SB 465. We've had a role in educating legislators, counties, and providers on the goals of the Behavioral Health Services Act and how it differs from the Mental Health Services Act. We offer that independent perspective on these reforms, and we fill in gaps in oversight and technical assistance that's been unaddressed in other areas. And really that, our FSP work is a critical driver for system accountability and improvement. In terms of the second priority here, ensuring that substance use disorder is incorporated throughout the Commission's work. As you could tell from the highlights in the previous slide, SUD had quite a bit of conversation in our work group. But really the rationale, again, for having this priority is that, SUD is one of the most significant and complex changes under the Behavioral Health Services Act. Again, as a standalone, previously under MHSA, it was through that co-occurring piece. But now, as SUD as a standalone, there's a whole new world in terms of the SUD community and the SUD, the population that is served that's not necessarily having a nexus to serious mental illnesses. And really that this impacts our funding streams and requires coordination amongst, the fiscal areas, clinical, and administrative systems. Also, we have work in our portfolio already for substance use disorders with our sub-pilots under the $20 million Mental Health Wellness Act projects that we have. And we need to think about it as it relates to other areas of our portfolio like the Behavioral Health Student Services Act, our full service partnerships, and Integration Partnership Fund, and even our advocacy work as well. And then also that our expertise within our commission and leadership is essential to guiding implementation and reducing stigma for substance use disorders and ensuring successful implementation under the Behavioral Health Services Act. Expanding peer behavioral health services, again, when the rationale is that, we've been working on elevating peer experiences, so we've become a trusted, credible entity to really help advocate for peer support and its proven benefits in improving outcomes, reducing costs, and addressing workforce shortages. And the importance of peers in providing culturally relevant whole person care. Also, it aligns with healthcare access, the Department of Healthcare Access and Information workforce development work. I talked a little bit about that in the WEP plan that's underway, and we want to be able to support that work, and we don't want to be duplicative, so wanting to make sure that what we're doing is complementary, but again, that we are advocates for peer services. And again, this is just a legacy priority for our commission that we've focused on for several years now. Finally, in terms of building the evidence base for the effectiveness of new and innovative statewide strategies, innovation being a new mandate or a different mandate here now under BHSA, whereas once it was at the county level, now it is at the state level and lies here with the commission, and the commission being the only entity dedicated to behavioral health innovation. So really trying to lean into that, keeping that as our priority, and tying sustainability directly to innovation highlights, to be able to highlight the challenges that our system faces with state and local funding volatility and the impacts of federal legislation like HR 1. So in terms of, the priorities, we've developed desired results. So this will be in everybody's packets. I know it's a little small on the screen here, but it's in everybody's packets. But for each of these priorities, the advisory committee worked on several results for each priority. A lot of them actually align with work that we're already doing again. So we weren't looking to necessarily add on to new work, but to lift the work that we're doing through that BHSA lens. But we do have some new areas that we think would be good to lean on. So I'll go through each of the results for each of the priorities. So for the priority 1, meeting the needs of people with the highest behavioral health needs, again, educating stakeholders on the distinction between Mental Health Services Act and the Behavioral Health Services Act. There's been a lot of confusion as people are kind of trying to get their sea legs and understand what those differences are. The commission can play a key role in trying to help with that. We can increase transparency and shared understanding of how the BHSA, how counties are allocating the BHSA resources to serve the BHSA priority populations. So once that information is available, we'll see integrated plans. In the out years, there will be the BOTR, which is the Behavioral Health Oversight and Accountability Transparency Report. We can become a trusted steward of knowledge and learnings regarding the full service partnerships. So really understanding what's happening in our FSPs. Like I said, we already have our legislative mandate to report on full service partnerships. And so we can really lean into that even more to understand those data. And it kind of ties into result number 4 is really learning more about the standard of care experienced by individuals served through FSPs. So it's one thing to have infrastructure and to be able to see the flow of people through the data, but to really understand the care experiences by those that this is all designed to assist and help. So we want to be able to think about some qualitative work we could do in that space to really understand those care experiences. And then the last under this priority 1 is increasing statewide understanding and visibility of how the housing scarcity and housing service mismatches across the full continuum of housing, including recovery housing, affect individuals served in FSPs. So again, really trying to lift up the housing piece because it's a big component for the BHSA now, and trying to think about how housing is related and how it's being implemented, particularly for individuals in full service partnerships. For priority 2, the substance use disorder continuum piece, we've got 4 results that we're proposing here in terms of, again, some of it's some work that we're already doing in our portfolio, result number 1 being one of them. So we've got our SUD pilot, which is looking to expand medications for addiction treatment providers and really helping to strengthen county infrastructure. I think we're learning a lot through those SUD pilots that we can use to help inform improvements that can be made in the system to help expand access. Result number 2 is one of our newer projects that we just, that the commission, all of you voted to for us to start working on our portfolio, and that is to expand SUD integration in our schools through our Behavioral Health Student Services Act work that we're doing. The third is looking to increase local level understanding and acceptance of evidence-based SUD, this evidence-based SUD service continuum through our advocacy grantees, so that we can help do our part to help reduce stigma, misinformation, and any philosophical resistance that that we see in our local communities. And then the fourth is increasing statewide understanding of the SUD continuum landscape, so we really can get a handle on what that landscape looks like, so that we can inform more effective integration of both mental health and substance use disorders in our public behavioral health system. The third priority, again, for peers and expanding peer behavioral health services. The first result is basically our peer respite projects that we have. So really, again, lifting up this expansion, visibility, and appropriate use of behavioral health services provided by peers, and having those as recovery-oriented alternatives within our crisis continuum. So we'll be releasing our peer respite RFP shortly. And we feel that definitely aligns within this third priority. Looking to elevate and strengthen the role of peers in serving individuals with both substance use and serious mental illnesses conditions. So, we've been hearing quite a bit that those two populations, there might be peers working in more of a mild to moderate non-specialty mental health space, but really trying to expand that work to really include substance use disorder and like expertise in substance use disorders and serious mental illness conditions, and doing that through education and training. And then the third result here being that the Commission will raise the statewide understanding of peers who reflect the priority populations, and that is going to be essential to the success of behavioral health services, including for FSPs. So really getting folks who align with and represent the priority populations providing peer services. And then the fourth priority is, again, anchored in that innovation work. And so 2 results here is uplifting best and promising practices and sustainability strategies through the Innovation Partnership Grants portfolio. And then also looking for exploring strategies for long-term public behavioral health system revenue stability, efficiency, and effectiveness, something else that has been a continued theme throughout our meetings. So that is an overview of all of the priorities and results, again, that we have been going through in our strategic plan. A little bit of it from our January meeting, continued on with more detail in our February meeting. I don't know if LRI has anything else to add before we open it up to commission discussion.
I would just add, Brenda, and thank you. That was a great presentation of the committee's discussions and where we've gotten so far. I would just add that I think commissioners can all appreciate, as you look at these priorities as well as the desired results that are attached to them, you can really imagine the reporting of progress around these. And so from a strategic planning perspective, we're always interested in understanding how are we measuring success? What will success look like? And so I think as you look at these results, a question to be posed to you all today is, are these results reflective of the results you want to see within these 4 priority areas? Are there other results you think are more important or equally important? Are there ways in which you would perhaps add nuance to these results so that there can be an even finer cast put on them. So with that, I would just ask Chair Rolette if he wants to facilitate the commission's discussion.
I will start with Commissioner Alvarez, and thank you.
Thank you. And thanks for allowing me to jump. I think we were going on that direction, and we went this direction because I have to leave early, so I appreciate it. So I have a couple of questions. One is, strategic plans are often both external and internal. We have goals that we want to have impact externally, and then we have goals that we want to have impact internally. And I'm curious, Brenda, Director Graylish, I heard you say, how are we utilizing our tools and our programs in order to most effectively meet these priorities? And I want to ask, I'm curious, is there going to be space either as part of this conversation and reflecting on the next few months of this current plan, or perhaps in the next plan, to think about our committees? When we started the committees, and we've revamped some of them, and the existing ones, we've just, how is it going? Reflecting on that, both from the commissioner experience, but also from the public. And I say that because there's just been so much continued interest in what is the role of our committees, both our commissioner-led committees as well as our external stakeholder committees, and how are they meaningfully contributing to the work of the commission. And this is the only opportunity to have those discussions. So I would just strongly encourage either to where it fits here or make sure we're dedicating time. And I want it on the record that we dedicate time to the next strategic plan for that conversation. And then my other question associated with that is where that space for our internal work as a body is being measured and we're being held accountable to that. And I only say that because we're only as strong externally as we are internally, and you all have done a tremendous job under your leadership and with the partnership of this team to move the commission in the right direction. And how do we account for that as commissioners? Because we want to not only celebrate the progress, but also make sure we're being held accountable to doing even more.
A lot of pieces to that. So, but those are great. No, it's great ideas. One of the things, and we kicked the committees off last year in the spring, right? Or really established them in the spring, kicked them off in the summertime. And so they've been running for several months now. We've now added the Strategic Plan Advisory Committee to it, and a couple other committees. And I think a couple things that we're looking to do. This part is just getting what the priorities and the results, getting that nailed down first. The second part of this project is for us to work with LRI to operationalize that, which is why I think Eric's asking, what do you want to see in terms of measurement? Because those are the things that we would report back through our committees, even up to the commission meeting, to be able to track progress over time. And one of the things that we have been thinking about is having a committee revisited conversation in August, so that we could kind of see how it's going, see how we might be able to refine, so that we are optimally using that time for these discussions. And so I think that those two things tie together in terms of these results and priorities and results that were coming up, that plus revisiting the committee discussion. And then one thing we've been working on internally, I haven't presented it here, but it'll probably be at the next commission meeting. We're kind of been loosely calling it Commission 2.0, or, we have 3 components to it. One is operational excellence, which is our internal operations. And so we've been spending probably most of the time on that. And I'm, as a leadership team within within CBH, then we're actually going to go to our staff teams, to the full staff team, to try to get input from them to lock that down. Also bringing that here to the commission. We have 2 other components to it, commissioner alignment and commission forward. For commissioner alignment, so we have alignment amongst our commissioners, this strategic plan update being a big part of that alignment and supporting that alignment, gets everybody on the same page. And then commission forward of how do we expand our stakeholders, and to be able to get more folks participating in our conversations. So we got that kind of in the pipeline as well. And then thinking about how all these 3 things go together in terms of, I think it's anchored in our strategic plan update. So this work actually is going to be our anchor as we think about how we optimize committee meetings and then how our internal teams work and track our own progress towards meeting these goals. So if that makes sense to you. But we're thinking of all three pieces. They're not all together yet, but they're on parallel tracks with the idea of them converging probably in the summertime.
Okay, and that all makes sense to me. I appreciate that because we want to have a meaningful time period of executing on those committees. I just don't want to lose sight of the combined lived experience committee, right? Because I think part of the challenge and the letters that we've received is there is difference of opinions of what is an effective contribution of that committee, and making sure we're clear as a commission, I think would be really helpful for future actions of what that committee can do.
Yep, thank you.
And Executive Director and Commissioner, I just wanted to make sure I watched the committee meeting for the Lived Experience Committee, the combined committee. And in part because Vice Chair asked me to, and I spoke with you, but also my point here is the evaluation of our committee structure, not towards to criticize, but to improve, and the process improvements that are associated with enacting that kind of change. And so I really do appreciate Commissioner Alvarez's point about the evaluation of our committee structure and providing stakeholders with an opportunity to provide some input there. And then secondly, I would encourage commissioners to, if you have an opportunity, to not just the combined committee that Vice Chair Chambers and Commissioner Alvarez are chairing, but all of our committees. If you have an opportunity to review and look at the presentations live as they are available, it is extraordinarily helpful. And that was an extraordinarily helpful discussion for me to understand the context of the letters that we had received. Other commissioners want to make comments. Yeah, Commissioner Bontrager, and we're going to go back to what our pattern.
Are we? Okay.
I interrupted. I'm sorry.
No worries. First of all, thank you. Very good. Under priority 4, I feel like there's an omission here. Priority 4 is build the evidence base for effectiveness of new and innovative statewide strategies. I think one of the results needs to be that we promote the equitable statewide implementation of innovative and evidence-based practices. Now, as an example, a decade ago, Drug Medi-Cal ODS was an innovation where we enhanced the SUD benefit in California under Medi-Cal. If you look at it today, only 40 counties have ODS. That means a third of them don't. And now we have BH Connect with evidence-based practices, and likely a lot of our rural counties won't be able to participate. Many of them are asking for exemptions. I think part of our job is to promote the equitable statewide implementation of any innovation. And I think that's one of our mandates, and I see it as an omission not to include it.
Thank you, Commissioner. Anyone else? Yes.
Thank you. This is exciting, actually. And I think during our meeting, one of the ideas, thoughts was brought up is how we arrange our commission meetings in the future, and what's the protocol and how those meetings are organized. For example, part 1 is priority 1. Part 2 is priority number 2, and then 3, and then 4, and organize the meetings that way so we're completely focused on our priorities throughout the commission meeting, and then put our work into each subcategory during the meeting. Then we're not, then everyone's on the same ball. I don't know. Have you put any thought into that?
Thank you. I mean, I think, are you talking about in terms of structuring our agenda, and so then we would have the, yep. Yeah, we could definitely think about how we could do that in a way that organizes it and makes sense, and yeah. Thank you.
Other comments from the commissioners? Yes.
Thank you so much for this. I will admit that I was out for most of the presentation, so sorry if you went over this, but I'm interested in just understanding result 5 around housing a little bit more under priority 1. And to your point, Eric, sort of like what did the committee, or what do you all think are the measurable sort of like outcomes of this result? Because to me it reads a little bit like understanding the housing and services mismatch, which I think we already do, right? That's like really out there. So like, is it really about that or outcomes or, so just like, yeah, what was the outcomes of this result?
Yeah, I think we'd have to operationalize all of it, but I'd say it might not be as common in knowledge outside of the housing folks that, you know, that there are mismatches happening. I mean, maybe some like boots on the ground folks, but, you know, I think it's coming from this notion, and we have particularly our full service partners, but really anybody who's being served under these dollars or our highest needs folks, you know, situations where somebody like might be placed in a housing situation because it's available, but not necessarily because it's the right fit, and maybe they don't have the right supports and stuff. And so really trying to think about how we can lift those issues up, and then what we can do to help educate, to really say, that's not going to be successful. You know, there's a good chance that's not the right way to do that. So what is the right way to do that? And what can we as a commission do to really highlight it, A, as an issue, and B, as what are the solutions to really help address that?
Okay, thanks. That's
Yeah.
helpful clarity. Okay, thank you.
And if, go ahead.
I was just going to comment that I think that's exactly the right kind of question to be asking today, which is, okay, so we see these results, help us understand what do they mean and how are we going to be measuring them, and bring back to us enough operational clarity so that we can understand what you have in mind. I think I don't want to forecast too much of what comes next in the committee process, but I think that's where we're going next with the next committee discussion, is to really think through what are the hows, the HOWS, to achieve all of these results that are listed here.
Awesome, thanks. That's really helpful. Thank you.
First, Brenda and team, thank you so much for all of the work on the strategic plan. I know that this has been a heavy lift. I especially want to laud the commitment to ensuring that as BHSA progresses, that we've updated and refreshed the strategic planning goals to align with what the voters have requested here in California. Sort of piggybacking on your statement around the understanding point, I actually want to sort of elevate and highlight that I think within priority 2, there is an absolute need to help educate, and that involves increasing statewide understanding of substance use disorders, the full continuum of care that are associated with substance use disorders, understanding that substance use disorders are distinct from mental health conditions. And I think that part of our goal as a commission does include that level of education, because right now, as BHSA sort of continues to mature and evolve in the years to come, we really need to make sure that there's a strong foundation so that counties and operators alike understand the nuance between those two types of issues.
Commissioner Gordon?
Yeah, apropos of result 2 under priority 2, I just wanted to let the commission know that that's a really tricky thing to do, and we will be doing some pilots in collaboration with our county partners. This is also a requirement upon the counties themselves to work on this. So we will be doing some pilots here, which will be starting very, very soon, within the next 60 days probably. So more than welcome to have commission members, the commission participate in looking at the approaches that are being tried. And I think it can be really, really helpful if it can be done well.
Thank you, Commissioner.
Other questions from commissioners on this side of the room? Yes.
I have a question and a comment.
And then back to you, Commissioner Robinson, afterwards.
Do we have a date for when we have to vote? I think it would be, I know it's really hard to plan out, but I think we want to have maximum attendance when we do.
Thank you. Yes, May.
Times of year.
It's going to be at our May commission meeting. I don't have that date off the top of my head. May 28th? May 28th. Okay. Yes, be there. Be there, be square.
Okay. Be there or be square. I have a little bit of a soapbox and a question related to it.
Commissioner, can you speak into the microphone, because I don't know if it's the recording's picking it up.
This is my soapbox. When I was working on fentanyl as a health policy consultant, I did some research and discovered that alcoholism far outweighs any other substance use disorder, and it's just ignored, really. We've set up mechanisms to refer people who come in with opioid overdoses to the ERs, and we connect them with services, but there's absolutely nothing for alcoholism. So I just wondered that if this, when you discussed substance use disorder, did you include or discuss alcoholism?
Go ahead. I'll give a point of feedback. As we did, and I think substance use disorders, just for the nomenclature for the group and any of the folks that are listening in, right, is a really sort of general term so that we don't have to say alcohol use disorder, stimulant use disorder, opioid use disorders. I do believe that was taken into consideration in our discussions. I wasn't present at the full committee meeting, but prior to that we had. And I will tell you, to reaffirm that, anytime that we look at any of our internal data in terms of individuals we're treating either in withdrawal management or residential settings, we're certainly very aware that alcohol is typically the leading primary diagnosis for individuals that we're serving in our programs for Medi-Cal eligible adults.
Wasn't encouraging specification because it's endless and it's always under-inclusive or over-inclusive. I just wanted to confirm that it did come up when you discussed this priority.
It did, and actually we updated the results to make it more general, because I think originally it was anchored to MAT, and we changed it to SUD as a general category for that exact reason.
Thank you. Really appreciate the conversation. A few questions from me. Just in how you set priorities, I'm surprised not to see a priority around workforce development. It's always just working in the healthcare system, we are always struggling to have enough providers of whatever type. And so it just seems like it's such a big issue. I'm surprised that's didn't bubble up to the top. That being said, I'd appreciate understanding what was your process for kind of determining which were the top priorities? Did you just discussion? Was it kind of voting? Or I just appreciate that. And then to Eric's question about measurement, some of as stated here, I worry how we measure this. For example, result 4 under priority 2, increase statewide understanding of the said service continuum. Do we have a current baseline understanding of what the understanding is, and how would we measure that? And then how would you know when it's increased? So this seems like a tough thing to measure. Not saying it can't be done, I just would love to understand the thinking there. And then the last thing, it's probably more of a comment than a question. I'm involved with a lot of strategic planning, and sometimes strategic plans fall flat when they don't have relevance to the end user or the front line. And I want to make sure that we build plans that resonate and feel relevant to users, not to us or to policymakers, but to people who are impacted by the policy. So appreciate your comments on those.
Yeah, no, great points. In terms of the process that we went through to develop these, it is a combination of a variety of things. So our staff team had developed the kind of top priorities based on BHSA, what we're doing in our portfolio, what we're hearing in terms of the needs, and also informed by our commission conversations that have happened over the last several months. So that kind of came up with the 4 priority areas, and then the commission staff team worked to develop the results it's like again based on what's done in our portfolio, but also what we're hearing from others, and then worked with our chair, our chair and vice chair, just on an initial run to kind of refine, and then took it out to the Strategic Plan Advisory Committee in February, and that was a public meeting. So we also got stakeholders that attended that as well, and had some more discussion, refinement, and then that refinement is what came here today. So that's been the process so far, and then here we are again today. More information, more ideas coming out here that's going to help us continue to refine this information, and we'll take back to the next Strategic Plan Advisory Committee in April finalize, and then goal is to come back here in May to have the final vote on it with everybody. In terms of how to increase understanding, it was kind of the same question coming up, so it's a good point. So we'll have to think about that in terms of how we would operationalize it, because are we going to do a statewide baseline understanding? And then, so maybe it's a matter of what materials we're putting out, like, and then quantifying like what we're doing, maybe engagement in our website. I don't know, we could think about some different ideas on how we might quantify that to measure that over time. And I love the idea on the relevance to the front line. I think that's who we do this for, so really keeping our customers in our, at the center of what we're trying to do. We want to get as much input as possible from our commissioners, stakeholders. We get a bunch of folks joining us here today and in our committee meetings. To be able to help inform this. I've been mentioning this when I'm out in different forums that we're doing this, so I'm putting it on the radar in any venue that I'm at that we're doing this. I'm telling folks this is kind of the areas we're looking at, trying to get folks to come to our meetings if they're interested to help us continue shaping this. And like I said, we'll keep working on this and iterating. This will get us through the rest of this year and next year, but I think we'll continue to learn, and that will actually roll into our next strategic plan. So.
And Director Graylish, to the Commissioner's first point about workforce, could you perhaps comment on that?
Yes, thank you. I thought I was writing it all down. I didn't write that one down. So workforce, a couple things with that. It's not explicitly mentioned in the FSPs, but it's kind of part of FSPs, and then the peers and peer workforce. Healthcare access and information has the bulk of the peer and all the funding for a peer workforce, and we are having opportunities to weigh in on that, and HCI is actually reaching out to us because they want the commission to weigh in on that. So that's really good. And we're wanting to promote to others too what HCI is doing so that we can even get more people to the HCI table for workforce. They are really zeroing in on the high needs population, those with complex behavioral health needs, and really trying to build out workforce in a way that I think has been talked about here, that I've even heard talked about here. So I think they're on a really good track to getting actually Commissioner Size on one of the wet work group with me as well. So they just met last week and had a really robust conversation. So we'll continue to do that with them. We don't want to duplicate their work, and like I said, they got all the funding for it, but we can definitely keep track of that and think about where there might be still some gaps, or where we can fill in, or what we can do to promote what's happening in that workforce area so that we can make sure our community knows what's happening.
Great. All right. I'm going to go to Commissioner, I'm sorry, Robinson, you had another comment? Yes, I got that. Okay. But because there's so many of you in my head, is a little bit concrete, sequential, I'm just going to keep going in order, and that way I won't miss anybody. But I'll come back to you, and then I'll come back to Commissioner Gordon. Commissioner Side, did you have a comment?
Yes, thank you. Thank you, Executive Director Graylish. Two quick comments. One is I wanted to express strong support for Commissioner Bontrager's comment. I think that there are a lot of, as we know, there are a lot of both new and incoming state initiatives and opportunities and innovations happening right now. And I'm concerned that if we don't pay attention to the equitable implementation across the state, including in small rural frontier counties, that we will have bifurcation of standards and access across the state. So I think that really paying explicit attention to that will be very important. DMC ODS is one example. I think there's a host of other examples. The second comment is to Eric, your question about how we know if we're making progress, just focusing on priority 2, because I'm not going to cover all the priorities here. That's what our committee is for, is around the SUD continuum. As you know, I think there was a lot of deliberate focus on the continuum. And I think that in that focus, what we were really talking about was ensuring that we were paying attention to the prevention side of the house on the substance use side, harm reduction services or risk reduction services, treatment services, which is really where people normally pay the most attention to just naturally, and then also recovery-oriented services as well as housing. And the recovery-oriented housing piece, I think, is also an area where we had some conversation. So I think that ensuring that this commission is able to focus on those areas across the continuum in similar ways as how we want to focus on mental health across the various ways in which we look at the continuum there as well, I think will be important. So thank you.
Okay. Now we'll come back on this side of the table to Commissioner Cross, and then after Commissioner Cross, we'll go to Commissioner Gordon to give additional comment, and then I'll make some final comments. Okay.
I was thinking about result 4 on priority 2 because Commissioner Robinson was talking about ways to collect data for it. And I don't know if like CBOs can do workshops for SUD, like if there's anyone who's willing to go out to schools or willing to go to community centers to just like host workshops. And then when workshops are done, you create a survey. Within the survey is asking your race, your age, what is it that you learned from the process? Would you come again? That kind of stuff. I feel like surveys might be reliable in those type of situations, just because that's the only way I can figure out increasing understanding. But also outreach would get more people coming out to these workshops. So over time, you're having more attendance, more data, and that can help you inform whether or not we're increasing understandings for SUD. So that's just kind of something that was going on in my mind.
Commissioner Gordon.
Thank you. Just a final comment on the SUD in schools. I think we have to be mindful that schools start now with 4-year-olds, and looking at a prevention agenda across the school years, I think could be very, very much effective because parents are paying attention, the community is paying attention, and I think substance abuse treatment is very tricky in schools. I think the prevention angle is much more of an open door. So,
all right. My comments, and I will make some comments on this one, is regarding priority 4. And first, I certainly agree with the overall. My preamble is one of the overall measures of an effectiveness of a strategic plan is a utility to a variety of constituents. And so I would hope that you were thinking about that. And so that's one. Number 2, in priority 4, the word effectiveness and a clear, explicit definition of what you mean by effectiveness. And here's an example. Oftentimes, what I've experienced over the years is that effectiveness does not include sustainability or that a sustainability of a new innovation is not an inculcated feature of the innovation. Here's this wonderful innovative idea. We did it for 3 years, and now, okay, we got to come up with some new funding to keep it going. Well, I think that's a failure, and I think that we've predicated a lot too much of our new innovative service on that notion. And so I would hope that the committee would consider inculcating sustainability in the definition of an effective priority 4 innovation. And the second example is alcove. I think that there's a great operational example of what we've done as a commission, but the question around sustainability has come up a lot in our discussion. And then how again, new innovation in the context of what's been said today, HR 1, Medicaid or Medi-Cal, and what that means as it pertains to sustainability in the realities that we face today. That's also important. And then how that translates to the end user. Does the end user understand that? But does the public understand that's part of effectiveness? And then as my colleague, Commissioner Palmano, always says, the data tells a story. Well, effectiveness is about being able to have data that tells a story about not anecdotal accounts, and I love that, about programs that work so well from people that have participated in those programs, but data that can be used not just in one geographic region, but it can be, again, translated into other geographic regions and potentially understood by the individuals that reside in that region. Too often the data is foreign to the end user or to the constituents that are affected by behavioral health, and then these new innovative programs that we bring into place, but the data, it's all anecdotal. The data that makes a difference, it doesn't translate into a language that they understand, and it's helpful. So again, it's the same thing that I appreciate about Alcove. We talk about sustainability and the problems associated with sustainability in Alcove, but we are not talking about, at least from my perspective, enough strategies at the beginning, at the very beginning, that not only uses data to inform service delivery, but also to inform strategies that will sustain the service. Somebody just said right, so okay, I'm glad. I'm glad you agree, because that's what data should do. It should say, "Hey, this is how you sustain this service. This is what you should do." And again, Commissioner Bontrager talked about that. The other commissioners are saying right, but that whole word effectiveness, okay, that I need that to be defined for me and under priority 4. I'll say more, but I'll save it as people are raising their hands now. Again.
I mean, I agree to a degree, but on the other hand, if innovative programs had sustainability, they wouldn't be asking for innovative funds. So, like, part of that initial funding is so they can demonstrate the concept in order to build sustainability. So, like, to just have that balance. And also the other thing, and right now, being a chief consultant on a 3-year pilot, I'm very much dealing with this, is that as a funding agency, taking our part in helping with the sustainability, is that, introductions or education, technical assistance, learning about some of these bureaucratic machines that can be difficult to navigate. But so, there's a balance where you don't want to cut off possibility because there isn't, a plan in perpetuity. I mean, that's,
One chair prerogative. The definition of effectiveness does not preclude a program that may sunset at the end of funding from being funded. It simply clearly, explicitly states that at the end of the funding, there is no sustainability plan, and understanding that. And sometimes you need ideas like that. So again, there's room for both, but remember my premise was, let's define effectiveness. Other question, comment?
Can I say a little something about that?
No, but no, go ahead.
I think that's great feedback. And I'm thinking in terms of priority 4, we could say build the evidence base for the effectiveness and sustainability of new and innovative statewide strategies, so that it's, sustainability is in that priority, so it's very clear. The result 1 is our Innovation Partnership Fund grants, and so it's the, basically the result 1 is us lifting up what's happening in those grants. Both sustainability and evaluation are part of the components of that. So things that have come up in the conversation of the Innovation Partnership Fund has been things like, well, it's innovate to kind of Commissioner Fariba's points, like these are things that are being tried out as tested, right? There's innovate. We don't know if it's even going to work, right? But that's what the evaluation part of the grant is for, is to see kind of how that plays out. We're actually asking also for sustainability planning for that, so that it's not like you get to the end of it and then you start thinking about sustainability, but that sustainability is being thought of as part of the project. And so, and again, it's like as part of the project, because this is kind of the petri dish of trying something new, they might find that it's not sustainable. I mean, that could be, or how much of a challenge it is to find it to be, sustainability, but it's upfront and known that is the configuration of the the grant and the projects that will be awarded. So hopefully that helps to clarify that it's all part of it. And so maybe we could just lift up that sustainability piece and the priorities so that it's very clear that that's a part of it, or from the get-go.
All right. Commissioner Callan, did you?
No, I was just talking about some of the innovative ideas where, the question was up if we work with if it's a public-private innovative fund. Possibly, I'm not saying the idea is if we're getting equity in whatever it is or getting a return on it, they would go back into the fund. And there are a lot of different new ideas coming out, and I think sustainability is really important, at least like you said, especially with Alcove. On the onset, having a very clear understanding of what the goal is and the possibility of sustainability after our funding is gone. Yep.
And again, to reiterate, the sustainability does not mean that or necessitate that ongoing programming. It simply means that you understand that we are going to define it in the context of this innovation. And there are some innovations that you're going to learn something. And what you learn is that, this wasn't a good idea. So, well, and it's truth. And that's, again, part of the learning that works for us. Other comments? Okay. Thank you. I don't know if you had any additional kind of comments.
Oh, sorry. Thank you, Eric. Can I get the slides just so I can go over next steps so everybody knows kind of where we're going on it? So the team could put up the slides, but essentially, I mentioned it already. We've got our April Strategic Plan Advisory Committee meeting. So we'll take all the feedback that you all have provided today. I think we also want to open up for public comment at some point too, but we'll take everything that we've gotten from commissioners today, and then when we get public comment, that will all inform our Strategic Plan and Advisory Committee meeting for April. And then again, all that information will then roll up into the final document, addendum, whatever we end up calling it, that we will be bringing forth to the commissioners, all of you, in May. And if everybody, it looks good to everybody, we get a vote to sign off on it, then we will work with the commission staff team, will work with LRI to operationalize it so we can start putting some metrics around it and then tracking progress through the rest of calendar year 2026 and on into 2027 and making that part of a standing agenda item. So,
and I think it's absolutely amazing and wonderful that the commissioner brought up that May 28th is the date of that next meeting. And May
28th. Oh, we haven't gotten that far. We're trying not to, but we've heard feedback.
May 28th is the date, and so you mark your calendars now. And certainly the strategic plan is again, it's the North Star for our commission. So we want everybody to be here. With that, no other commissioner comments? Amariani, we'll transition to you for public comment.
Thank you. We do not have any public comment for this item.
I will see if our committee chairs, Karen and Commissioner Larson, Commissioner Larson and Commissioner Fernandez, have any other final comments? Okay. With that, thank you all very much. Thank you very much. Appreciate it. Okay, so I have wonderful bad news. We are well ahead of schedule, so we're going to take a break. Let's reconvene at what time are you recommending that we reconvene? 2:30? Does that work? Okay, we'll try 2:30. We will try 2:30. Okay, thank you. Just wanted to let everyone know that we completed agenda item 14. That was your stretch break. We are now at agenda item 15. Commissioners, welcome back. And we are moving on to the 15th and nearly final agenda item for the day. Review and consideration of the of legislation for the Commission to support during the 2026 legislative session. We will hear from Kendra Zoller, who does everything for the Commission. Thank you, Kendra. Thank you. Deputy Director of Legislation and External Affairs. It is an inculcated feature of everybody's job here. You all are amazing, all of you. As well as, are you the only presenter here today? They're online. As well as Moran Aghnafar, Policy Director at Cal Voices, Amir Rashid, Director of Legislative Affairs at California Behavioral Health Directors Association, Kylie Johnson, Legislative Assistant for Assembly Member Gonzalez. Again, Kendra, thank you for everything that you do for the Commission, but especially thank you for planning and directing our legislative agenda. We'll turn it over to you.
Thank you so much. Thank you. Okay, before I get into the presentation, I know Brenda already mentioned this earlier, but our sponsored bill, Assembly Bill AB 2003 by Assemblymember Berman, passed the Assembly Education Committee this week with a ton of support. I want to thank Cayenne for being our co-sponsor and Commissioner Madrigal-Wise for being our subject matter expert and champion, so we're very excited. All right, moving on to the bills we have today. I want to explain how they were chosen. They were prepared before the surge of bill introductions on February 20th, which marked the deadline for introducing new bills. So many bills came out after our committee met, so the 3 today were introduced early in the process, and we will have more bills coming back in April and May. So this does not represent all the behavioral health bills out there because we did this so early. All 3 of the bills today were brought to us by stakeholders and were put through our committee's decision-making framework to ensure alignment with the Commission. This includes Assembly Bill 96 by Assemblymember Jackson on peer support specialists, Assembly Bill 1540 by Assemblymember Gonzalez on 988, and a proposed budget item that would eliminate the mobile crisis benefit. AB 96 and AB 1540 were approved by the LEX Committee to recommend support, and then they recommended opposed to the mobile crisis benefit cut. So we will begin with Assembly Bill 96, sponsored by Cal Voices and CBHDA. We have Marin Aghnafar, Policy Director at Cal Voices, and Amir Rashid, Director of Legislative Affairs at CBHDA, who will join us virtually to present on the bill, which is moving fast through the legislature. So welcome, please go ahead.
Should I start?
Yes.
Okay. Good afternoon, commissioners. Thank you for the opportunity to discuss AB 96 Jackson. My name is Marin Aghnafar. I serve as the Policy Director at Cal Voices, the oldest peer-led organization in California. On behalf of CBHD and Cal Voices, we would like to thank Assemblymember Jackson for authoring this bill. Peer support specialists identify themselves as having experience with recovering from mental illness or substance use disorder, or both, either as a consumer of these services or as a parent or family member of the consumer. As amended, AB 96 will remove the high school requirement for medical peer support specialist certification, thereby eliminating a barrier for individuals seeking certification. In 2024, CalMesa, the certifying entity for peer support specialists, hired RAND, a research organization, to evaluate the early implementation of California's peer support specialist certification. According to that report, the requirement of high school diploma creates significant impediments for applicants, especially those facing administrative challenge in obtaining transcripts and individuals whose education has been disrupted by addiction or other life circumstances. At Cal Voices, we also conducted surveys, and most respondents said the high school requirement is not needed. California has established a standard medical peer support specialist certification program as outlined in SB 803. The Department of Healthcare Services sets the core competency requirements and scope of practice for certified peer specialists. The core competencies and value for peer workers highlight recovery-oriented, person-centered, relationship-focused, and trauma-informed approach. The focus is on self-determination and the significance of shared experience in recovery and healing. It's a powerful movement. Peer support specialists must complete an 80-hour training program provided by CalMesa-approved training entity. The certification remains valid for 2 years. To renew, they must also complete 20 hours of continuing education, including 6 hours in law and ethics. Removing the high school diploma/equivalent requirement will not impact the curriculum, core competencies, or ethical mandate for certified medical peer support specialists. Instead, it will provide capable candidates without a high school diploma with a pathway to become certified as a peer support specialist. Thank you for the opportunity to discuss AB 96, and we hope you will support this important bill. Thank you for your time.
Okay, thank you so much. We can open it up for questions on this bill here, or we can wait till the end.
Amir is not here?
I don't think he's joined yet.
Got it. Thank you.
Commissioners, what's your pleasure? Oh, keep going. All right.
Okay, great. Thank you. Next, we have AB 1540 by Assemblymember Gonzalez, and we have Kyle Johnson, Legislative Assistant with the Assemblymember's Office, on the line. This bill is sponsored by Equality California, the California Alliance of Child and Family Services, and the Sacramento LGBTQ+ Center. So please go ahead, Kyle.
Hi, folks. Can you hear me okay?
Yes. Yes.
Perfect. Awesome. Well, it's a pleasure to be with you all today. My name is Kyle Johnson. I serve as a legislative and communications aide for Assemblymember Mark Gonzalez, who represents downtown LA and some of the surrounding communities. I want to thank you all for being here today and allowing me to come present. Just a little bit of background on AB 1540. So since 2022, the 988 system allowed for a press 3 option. So when you dial 988, it currently allows different routing options. Press 1 is for veterans, press 2 is for Spanish speaking. And prior to this current federal administration, press 3 allowed for LGBTQ+ youth to be routed to a specialized subnetwork. On July 17th last year, the president ended all contracts with the press 3 providers, effectively canceling the press 3 program. Since then, we have seen a lot of LGBTQ+ youth struggle to really find the mental health resources that are specialized and designed for them. As many of you know, LGBTQ+ mental health rates are extremely low. They commit suicide at much higher rates or attempt suicide at much higher rates. We have some studies by the CDC that suggest 20% of LGBTQ+ youth attempt suicide in their lifetime. And that's compared to 6% of their heterosexual peers. And that number jumps to 26% when we're talking about TGI folks. Especially under this current political climate, there's not a lot of studies being done on the impacts of political rhetoric on LGBTQ+ youth, but we anticipate that those results have climbed. Our bill, AB 1540, would request the Cal HHS and OES to submit a request to the federal government and authorize California to reestablish its own Press 3 network. We are basing this program off of the Press 4 program in Washington State, which is a Native and Indigenous hotline. I'm happy to answer any additional questions, and I know that this bill is quite technical, and so if there are any questions, I'm happy to answer it, but we have seen a breadth of support on this bill and a coalition that has really been pushing and mobilizing around this bill. Thank you.
Seeing no questions. Oh, one question. Commissioner Brown.
My question, does this bill just restore the LGBTQ+ of the Press 3, or does it restore veterans and whatever the other one was that was mentioned as well?
Great question. So under the president's executive it wasn't an executive order. It was just the not extending the contracts. The veterans in the Spanish line still remain active at the federal level and so the national level. So those options, if you still dial 988 today, I actually just tested this recently, but it does prompt you with those two options still. And then the press 3 is no longer there. It was removed.
Other questions? Okay, back to you, Kendra.
Okay, last item is a budget item that was brought to us by CBHDA and a lot of other stakeholders. I will introduce it and then pass it to Amar that I see he is on and for any additions or technical questions. So our state is at risk of losing critical life-saving mobile crisis intervention services for hundreds of thousands of Californians due to a proposed change in the governor's budget. The enhanced federal Medicaid matching rate for mobile crisis services is available until December 31st, 2026, and federal authorization for the benefit extends through March 31st, 2027. The impending expiration of this support creates a critical funding gap. The proposed budget the governor put out in January proposes a state amendment plan to make this benefit optional rather than mandatory for counties beginning April 1st, 2027. This optional approach avoids a state mandate, thereby eliminating the state's obligation to pay for increased costs. The financial burden would fall onto the counties if they opt to provide the services, potentially jeopardizing their continued provision, and particularly in rural and underserved communities. Mobile crisis teams are currently a cornerstone of our behavioral health system. They're designed to ensure people experiencing behavioral health crises are met with the right responders at the right time in the right setting. Importantly, while established for Medi-Cal members, these teams serve everyone regardless of insurance status. As of December 2024, 48 counties are approved, covering 98% of Medi-Cal members statewide, but their reach extends beyond this. Our commission is very familiar with the impact and success of these teams. We've supported them through our work with the original Mental Health Wellness Act grants, then called Triage, which funded several teams. If this proposal is adopted, counties will have to absorb significant new costs at a time when they are already experiencing financial strain and implementing the Behavioral Health Services Act. This additional burden could force many counties into painful decisions, scaling back or eliminating these benefits entirely. This is particularly consequential as California is actively implementing a comprehensive crisis response framework for 988, where mobile crisis is a huge component. So this budget proposal directly undermines those critical efforts. It risks rolling back the millions already invested by the state and counties in building this statewide benefit, leaving vulnerable individuals without access to essential community-based crises response. As I mentioned, CBHDA is on the line if there's any technical questions or any other comments they'd like to add. And the LEX committee, the legislative committee, recommended the commission oppose this cut. So I will pass it to CBHDA.
Thank you so much. Amar Rashid here, Director of Legislative Affairs at the County Behavioral Health Directors Association of California. I think you summarized the budget request pretty well. I think I would simply add how imperative it is, I think, as that we continue to advocate to ensure that mobile crisis maintains its funding levels. As you noted, there's a significant number of services that have been incredibly impactful all over the state. And the coalition of support on this particular ask has been growing pretty substantially and has a pretty diverse array of organizations. So we would look forward to having you all join us. I'm available if there's any questions.
Any questions from commissioners? And Kendra, I thank you for making it clear that the commission's history around supporting mobile crisis, maybe not mobile crisis specifically, but services related to mobile crisis has been fairly robust. Any questions? We can take questions for all three now.
talking to myself. Okay, if we could go back to AB 96, the speaker said something about what was highlighted, recovery, trauma-informed, self-determination. What were the other things on that list?
So there are 17 components, core components. And so do you want me to read those
No,
two?
not all 17, but you did highlight some specifics. I was
Oh,
curious about.
So it's basically the core components, and the principle is recovery oriented, person centered, and relationship focused.
That's it. Thank you so much.
You're very welcome.
Other comments or questions? Right. Yes.
Just to say, we had pretty robust discussion during our Lex committee on these. There was pretty unanimous support for it. I have one clarifying question. With reduced federal participation for the mobile crisis, do we have a sense of what the increased costs to the state or the counties would be? How big is the nut?
I think CBHD has an estimate, if you'd like to share.
I'm so sorry, I could barely hear the question. Would you be able to repeat that for me?
The question was, what is the potential burden on counties given if this funding goes away?
Incredibly significant, and I can pull up and get a number to you shortly if you just give me a moment. Happy to find that estimate for you.
Okay, thank you. Other questions? While CBHDA is pulling up that number, maybe we'll transition to public comment. We'll go to you now, Amariani.
Thank you. We have 4 public comments virtually. Our first comment is from Stacy.
Thank you, Stacy Hiramoto with Remco and Safe Passages. First of all, thank the Commission for supporting AB 96 and AB 1540 and your budget proposal. We have the same positions, and thank you for bringing this to the Commission's attention. On February 19th, when the Legislative Committee met, we did not yet have a sponsor for our budget request. And I was hoping that maybe Carly will talk about it too. But I think I did talk about this, though, at the Ledge Committee, that Remco, Safe Passages, and the California Behavioral Health Association are co-sponsoring a budget request. And we do have an author, and it's formal now, Assemblymember Gail Pallerin, to sustain the CRDP, the California Reducing Disparities Project. This funding would be for 2 years. And this commission was the originator of the CRDP, and we would like you to help us sustain it. Thank you.
Thank you. Our next comment is from Carly.
Hi, folks. Thanks, Stacy, for teeing me up there. Carly Stelzer on behalf of the California Behavioral Health Association wanted to express that we are also in support of AB 96. We have some concerns from our call center members on some of the technical pieces of AB 1540, but we have been working very closely with the author's office, really appreciate the partnership there, and we'll continue to work on some amendments so that our call center members feel comfortable with the bill as it progresses. And just because Stacy mentioned it, I wanted to flag we did already share our other bills and budget asks, as mentioned, the CRDP budget ask with Kendra for that to be reviewed at the next Lex committee. So thank you and appreciate it.
Thank you. Our next comment is from Teresa.
Hi, Teresa Comstock. On behalf of the California Association of Local Behavioral Health Boards and Commissions, and also the California Coalition for Behavioral Health, we also oppose the cuts to mobile crisis. Thanks.
Thank you. Our last comment is from Steve.
Hello, my name's Steve McNally. Can you hear me okay?
We can.
I always like to check. I apologize for commenting so much, but these are topics that are very important. AB 96 is one that I followed immensely because it gave a pathway to billing and managed healthcare before it was gutted. So I'm not against removing the education, certainly, but I'm more concerned about the approximately 8,000 certified peers currently in the state finding employment. And maybe that goes back to sustainability and how do you, once you get something going, how do you actually implement it, to the earlier discussions? And I feel much more comfortable now that SB 324 is on the table. And I guess maybe that would be something to come back to the legislative committee and ask about. But that does provide a pathway for certified peers, much cleaner and the oops, I'm done. Okay. Goodbye. Thank you.
That was our last public comment.
I note that there may be some additional questions from commissioners in the room on these bills for Kendra. So if there are, you can ask those questions now. Or sometimes it's just good to be wrong, and maybe I'm just wrong. All right. Thank you, Amariani. Thank you, Kendra. Now, we will now vote on each motion separately. And the first motion, and I'm sure I'm waiting for it to on the screen. Okay. That the commission support AB 96 Jackson and direct staff to communicate its position to the legislature and the governor.
I'd make the motion.
All right, there's.
Do we have a second?
Second.
Thank you. We have a motion and a second on the floor for the motion on the screen to support AB 96 and direct staff to communicate the position to the governor. Commissioner Alvarez. Marking absent. Commissioner Baer.
Aye.
Commissioner Bernick. Marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch. Marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale. Marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz. Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Pulmano.
Not voting.
Commissioner Hill. Marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal Weiss.
Aye.
Commissioner Mitchell. Marking absent. Commissioner Robinson. Commissioner Southard. Marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy. Marking absent. Commissioner Wilkes. Marking absent. Commissioner Chambers. Marking absent. Chair Roulette.
Aye.
Motion passes.
Thank you, Sandra. Let's move to the second motion. That the commission supports AB 1540 Gonzalez and directs staff to communicate its position to the legislature and the governor. We have a motion. All right. Do we have a second?
Second.
Thank you.
I'm sorry, who was the second?
Pam
Bear.
Bear.
Thank you, Commissioner Bear. We have a motion and a second for the motion on the floor for the commission to support AB 1540 Gonzalez and direct staff to communicate its position to the legislature and the government. Commissioner Alvarez, marking absent. Commissioner Baer.
Aye.
Commissioner Bernick, marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch, marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale, marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz. Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Swartz. Pulmano.
Not voting.
Commissioner Hill. Marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal-Weiss.
Aye.
Commissioner Mitchell, marking absent. Commissioner Robinson.
Aye.
Commissioner Southard, marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy, marking absent. Commissioner Wilkes, marking absent. Commissioner Chambers, marking absent. Chair Roulette.
Aye.
Motion passes.
Thank you. If you can put on the last motion on the screen. That the commission opposes the proposed budget cut to the mobile crisis benefit and directs staff to communicate its position to the legislature and the governor. I'll move it.
I'll second.
I'll second.
So we have a motion from Commissioner Roulette and a second from Commissioner Larson. On the floor is that the commission opposes the proposed budget cut to the mobile.
Is there a chance to hear, I mean, before I vote, I'd like to know what we're asking the state as far as how much?
Yes, I have an answer.
Okay.
The estimate is 130 to 160 million estimate.
Wow. Okay. Big number.
Okay, as we had a motion and a second for the commission to oppose the proposed budget cut to the mobile crisis benefit and direct staff to communicate its position to the legislature and the governor. Commissioner Alvarez, marking absent. Commissioner Baer.
Aye.
Commissioner Bernick, marking absent. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch, marking absent. Commissioner Callan.
Aye.
Commissioner Carnevale, marking absent. Commissioner Contreras.
Aye.
Commissioner Designee Swartz. Commissioner Cross.
Aye.
Commissioner Fairweather.
Aye.
Commissioner Fernandez.
Aye.
Commissioner Gordon.
Aye.
Commissioner Designee Pomano. Commissioner Hill, marking absent. Commissioner Larson.
Aye.
Commissioner Madrigal-Weiss.
Aye.
Commissioner Mitchell, marking absent. Commissioner Robinson. Commissioner Southard, marking absent. Commissioner Thomas Beckett.
Aye.
Commissioner Sy, marking absent. Commissioner Wilkes, marking absent. Commissioner Chambers, marking absent. Chair Roulette.
Aye.
Motion passes.
Thank you, Kendra. And great job, as always. And thank you to all of those who supported you, Kendra. Agenda item 16, recess. I'd like to thank okay. I'd like to thank all of our commissioners as well as members of the public and commission staff on the first day of our two-day March meeting. We will reconvene tomorrow at CBH headquarters, yes, 1 hour early. You gave me birthday cake, what can I say? At 9 a.m. Tomorrow's meeting will adjourn at 1 p.m. In the meantime, I invite everyone, members of the public, stakeholders, staff, and commissioners to join us for a get-together at Field Work from 4 to 6 p.m. Field Work is located at 1805 Capitol Avenue in Sacramento, less than a mile from here. Look forward to seeing you after the meeting. With that, I now call for a recess of the meeting. And do we need a motion and a second to recess? We do not. Thank you once again to everyone, and I hope to see you all at Field Work at 4 p.m. in exactly 59 minutes. Thank you all.